A good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on chest pain in OPD, practical approach to every physician. I'm Shabnam, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the evening, Dr. Navonil Dutta. Dr. Navonil Dutta is MBBS FIC and is currently pursuing DNB pulmonology. Dr. Navonil has been serving since 2020, including a frontline doctor during the COVID-19 pandemic. He has been actively teaching and moderating seminars since 2022 and is a regular contributor to CMEs with the West Bengal Rheumatology Association. During his MBBS, he was a part of South Asian Medical Students Association and won the Best Poster Presentation Award at Conscience 2019 JIPMA. We are honored to have him with us today to share his expertise on chest pain in OPD. Over to you, Dr. Navonil.
Good evening, everyone. I'm extremely thrilled to have such a wonderful audience. It's almost 100 participants, and I thank each one of you from the bottom of my heart. As I was just scrolling through the participant list, there are very few familiar faces. There are some completely unknown ones. I have some of my very dear juniors here, people who have been, my students at some point of time, and to see them do so well, Dr. Sneha, Dr. Pritha, and many more. I might be missing out on a few names, but I really thank you all from the bottom of my heart. And a very big thank you to the entire Mediversal team, to the ones without mentioning whom I think I shouldn't be starting this, because number one, they've always kept the best topics for me, thankfully. And knowing that, that I am going through a pretty hectic schedule at this point of time, they've always had this faith that I'll be able to do the presentation with the best of my abilities. So thank you to each one. Thank you to Ifka. Thank you to Srinivas sir, Vijay sir, to Shabnam, to Durgesh sir, and to the entire Mediversal team who are directly or indirectly behind the scenes as well. So thank you so much for joining in. I really promise you that we'll be having a session of fun, of quizzes, and it'll be a really very interactive session. So my earnest request is, keep your doubts written in a piece of paper. After I finish a unit, I will give you the scope to ask doubts. I'll take up doubts for maybe 2 to 3 minutes. And following that, we can step into the next section. That is usually how my webinars are planned. It is going to be very Socratic. It's going to be conversations from both ends. So let's get on to this journey. And lots of love to each one of you. And welcome and a very good evening. I hope you all are doing hale and hearty. Okay. So am I audible? Can I just get this one confirmation before I begin? Am I audible and am I visible?
Yes, Dr. Navonil, you are audible as well.
Yes, fantastic. Okay. So I will be sharing my screen, and here it is. Okay. Can you give me a confirmation if my screen is visible?
Yes, Doctor.
Yes.
Okay. Good. Okay. So the topic of the day is chest pain in OPD. Now, when I first got this topic, before I wanted to plan out the structure of this webinar, there were two predominant struggles that I went through, to be very honest. The first struggle being the fact that when it's chest pain and then there's OPD, I have to think of the different causes that will present as an OP patient. And to be very honest, most of these cases warrant a condition where predominantly I have to be careful that whether the patient who is coming to me in chest pain or with chest pain, whether it is acute or whether it is chronic, is having something life-threatening. And as a physician, That is our first rule. For anyone who's working in the OP, be it a cardiac cause, be it a pulmonary cause, be it a gastrointestinal cause, be it any cause of chest pain, something which I'll be talking of subsequently in my future slides. My first target as a physician is to know that I will not miss out something which is critical. That is exactly where my finish, where my success as a physician comes in. Am I able to refer the most serious patient to the hospital in the right window period? Because there are so many cases of MI who come to the OP, and it is the vigilance of the treating physician who sends this person at the right time to the hospital or to the nearby, cardiac facilities. And there are so many times that a life is saved because, as the great cardiologist Dr. Braunwald says, time is muscle. And whenever we talk of muscle, in this case, we are predominantly meaning the heart. So every second that you lose, every minute that you lose, you are losing a part of your muscle, which is never going to come back. So this leads me to the first topic of the day, where I have tried listing all the predominant causes of chest pain. And in today's webinar, I will be specifically targeting the ones which are severe, which are serious, and which warrant immediate attention. The reason being, it is such a vast topic that it is literally. I think there's somebody writing on the screen. Can we clear that, Shabnam, Ifka?
Yes, doctor, I'll clear it.
Yeah. Can we please clear this? Yeah. Yeah. Thank you. Thank you so much. Yeah. So I've tried listing down all the causes, and I've tried talking in details about the specific diseases which should not be missed, because missing them will really cost a life. And that is exactly what we need to get better at. Are we more vigilant? Are we more confident in seeing cases wherein we don't miss the serious ones? Because at the end of the day, those are the lives that count. So beginning this, and before I begin, as I always say, I'll always thank my teachers from whom I've learned the art of medicine, the art of radiology, and out of the numerous other ones, I think these two people need a special mentioning. Dr. Dilip sir, who's a consultant cardiologist and rheumatologist from Mehta Hospital, Chennai, and Dr. Zainab Vora and her little baby, Zara, who have been very, very, very pivotal in being where I am today and whatever little I'm doing today. I think there's some kind of a writing which is happening. I appreciate it. Yeah. Okay. So, and I'd also request the mics to be muted, please. The other mics to be muted. Yes, so that the session does not get interrupted and we have a very, very free flow of things happening. Okay. So Dr. Zainab Vora happens to be a senior radiologist from AIIMS New Delhi, and having been a student for the last 2 to 3 years, radiology is something particularly, apart from the other systems, is something which I've learned very diligently from her. So I wish to thank both of them, and a lot of my regards to my seniors, my doctors, and my other fellow teachers who have helped me throughout this journey. So thank you to each one of you before I begin this. So my first slide says, not all that aches are gassy, and not all that aches are the marks of a Cupid's arrow. Now, why did I say this? The most commonly missed cases of heart attack predominantly, and chest pains being fatal predominantly, happen because people are often reluctant to visit the nearby health facilities. Most of us consider any kind of substernal or central chest discomfort as one which arises due to an acidity, maybe an acid reflux, or even at times due to what we call as gas bloats. And the other ones are ones where we are dealing with a lot of emotional stress, probably. The ones going through a painful heartbreak, ones going through emotional or financial losses. My heart goes out to all of you. But in case you feel that it is a chest pain which is coming with a lot of other complications like sweating, like shortness of breath, it is time to really think that it is not depression. It is not Cupid's arrow. It's not a heartbreak. So this is the time which helps us to focus on the first slide, where we know what are the other causes of an acute chest discomfort. If you can see the pie chart, you can see this, that you can see this pie chart where you can see that 42% of cases are due to gastrointestinal causes. 31% of cases of chest pain are due to ischemic heart diseases. So these are the predominant conditions. And from the pulmonary causes, 2% cases are due to pulmonary embolism, and 2% come from the cases of pleuritis or inflammation of the pleural cavity. So predominantly, if I have to take out a case of chest pain, I have to rule out the cardiac causes first, because these are the ones which are really going to be fatal. These are the ones which are going to cost us my life. Again, looking at the flow chart on the right hand side, you can see there are a number of other causes, but trust me, the moment we have ruled out the fatal causes, it becomes really easy for us. It becomes really easy for us to rule out the psychological causes, because any psychological cause is a diagnosis of exclusion. That's what we say. It's a diagnosis of exclusion, where every other finding, the clinical findings, the lab findings, the imaging findings, everything coming normal, our clinical suspicion is low. There is a significant history of stressor. That is what leads us to thinking a case of panic disorder, maybe a panic attack, maybe causing chest discomfort. Infections like herpes zoster are pretty easy to diagnose, because you can open the vest or open the t-shirt and check for a dermatomal distribution of the skin lesions, and you can easily understand that yes, it is a herpes zoster skin lesions which is causing pain, which is causing erythema and redness. So these are causes which are not going to lead to death. These are not causes which will be fatal if misdiagnosed. But and even if I talk of the muscular causes, like the musculoskeletal causes like costochondritis, where you can easily palpate along the ribs and the costal cartilages. When you palpate along the ribs and the costal cartilages, you find there is swelling, you find there is tenderness, you find associated vitamin deficiencies, probably vitamin D and calcium deficiencies. You have a history of a middle-aged woman who's also suffering from osteoporosis. All of this leads us to the diagnosis of a musculoskeletal issue like a costochondritis as well. But the ones which require the closest of attention are the cardiovascular and the pulmonary causes. And among the cardiovascular causes, the broadest spectrum of what we need to understand and study is what we call the ACS, or the acute coronary syndrome. So that takes me on to my next slide. That's acute coronary syndrome. Here we'll be studying about the basic approach to chest pain, basic approach to ACS. I will predominantly talk of the therapies that we can give to the patient on the way to the hospital, maybe from the clinic on the way to the hospital. I will not talk of what is done inside the emergency, because that will be a long talk, honestly. But very honestly, I can suggest the Mediversal team that we can have another part 2 of this webinar, where we can talk about what to do in the emergency once that patient has come, because this is more of a OPD based discussion. What to do in the emergency once that patient has come, how to deal with an ACS in the emergency. We can talk of what to do, how to reperfuse, how to thrombolyze. We can talk of all those things. But for now, let's keep it restricted to the OPD based treatment and maybe a bit of adjunctive treatment, so that the patient has a larger window period to reach the hospital. Whenever I talk of chest pain and ACS, I need to first understand what are the clinical features that are suggestive of an acute coronary syndrome. So, chest pain, but what kind of a pain? A chest pain at rest, a pain which is a crescendo, decrescendo type of a pain. That means the intensity of the pain is increasing with time. And a new onset chest pain, something which is, within the last 2 months, let's say. Any new onset chest pain, any rest pain, any crescendo pain should make you think about ACS. Again, it is always said, in cases of a cardiac cause of chest pain, it is better that you overdiagnose than underdiagnose. So any kind of chest pain, it says it's a standard line that any chest pain in any individual, be it whichever age group they fall in, should not be taken lightly. Especially if it is a pain suggestive of ACS, you cannot take this pain lightly. Associated symptoms may be there. There may be sweating, which is called diaphoresis. There may be radiation. And when we talk of radiation of a chest pain due to a heart attack or an MI, I want to see the comment box. Can you tell me what kind of radiations do you find? Where will the pain of a heart attack usually radiate to? Can I find some answers in the chat box? Can I know? Where do the chest pain cases radiate? Okay. Okay, a lot of answers coming. Left shoulder, jaw, back, shoulder, left. Okay, when you're talking of the arm, can you specify which arm? Can you specify which arm? Okay, majority answers being left arm. Majority answers being left arm, jaw, neck. Perfect, perfect. Okay, so welcome to the first dhamaka of the day. So a recent study, and I'm giving you the reference. You can go to Harrison's Principles of Internal Medicine, which is the 22nd edition has been released. You can even consult the Braunwald's, the cardiology book of Braunwald's. It says that majorly the pain is radiated to the right shoulder and the right arm. So yes, contrary to what most of us knew, it is majorly the pain that is radiated to the right arm. Usually it can be anywhere from this region, from the central area of the chest to the right arm, to the left arm. But as I said, more sensitivity with heart attack or MI has been found with radiations to the right shoulder blade. It can radiate to the back. Sometimes it can radiate to your neck, to your jaws. Those are okay. But data-wise, study-wise, it clearly says that the incidence of MI is more with radiation of pain to the right shoulder. What kind of a chest pain is it? It's a central chest pain. It's a central chest pain. Unlike what most people think, okay, a left-sided chest pain is probably more suggestive of ACS. No, it's mainly a central chest pain. It's a squeezing kind of chest pain. And when you ask the patient, what is the pain like, they are unable to describe the pain. They are only going to show something squeezing, which in older literatures has often been called as the Levine sign, Levine, Levine sign, which causes a constrictive, a squeezing central chest sensation. But there are most patients I've seen, trust me, who do not complain of Levine sign. All they say is, I am feeling a substernal discomfort, a central or a substernal discomfort. Sometimes the pain radiating to either shoulder blades, mainly rights. Along with it, you have diaphoresis. You have, along with it, if you have a low BP, along with it, if you have crepes on the auscultation in the chest, which is very suggestive of pulmonary edema. On ECG, if you're finding a ventricular arrhythmia, trust me, these are direct indicators that this patient has come to you with ACS, acute coronary syndrome. Am I clear? Okay. Whenever I have such a patient, I have three pillars of evaluation. My first pillar is an ECG. And the standard recommendations are the ECG has to be taken within 10 minutes. Again, it's something that's my recommendation and my request to all the physicians or my juniors or my fellow colleagues who are practicing. Even in the OP, it is mandatory that you have an ECG machine. It is something which is mandatory because you cannot diagnose an MI. The only way you can diagnose an MI probably in the OP is by seeing some changes of ECG. Often you may not get ECG changes, which I will talk of in the subsequent slides, but having an ECG in your OP is something which is mandatory. Today, right now, there are so many brands. I don't want to sound like I'm promoting a brand, but there are so many brands which have come up with a pencil battery-like strip, which can give you a total ECG recording of all the 12 leads. And within a span of 5 minutes, you'll be able to get a report, and that will be an AI-generated report. There are so many, brands like Tricog, like Spandan. You can even, the ones who have been following Shark Tank over the last few years will get a hack of what I'm saying. But what I really want you to know is please keep an ECG monitor with you. It is a mandate even at home, and it is even a mandate, especially for ones when you're practicing in the OP. So my first thing is an ECG. My second thing, as I said, the ECG should be done within 10 minutes of patient coming to you. And this is a standard recommendation of a quality of care. Any hospital or any place where a clinician is unable to do an ECG in a suspected case of chest pain or ACS within 10 minutes, this is equal to leading the patient to a muscle necrosis and muscle injury at some point of time ahead. So, the second thing is a biomarker evaluation, where no more are we there in this world of cardiac troponin T and I. I know there'll be many people asking me which is more sensitive, troponin T, I. Trust me, today we have a higher sensitive cardiac troponins, which are much more sensitive than cardiac troponin I and T. 10 years ago, 15 years ago, the rule was I is more specific than T. But today we have HS troponins, which are high sensitivity cardiac troponins, which can pick up even a minute amount of muscle injury, cardiac muscle injury, and that may be transmitted on the reports being positive. So the third pillar is an imaging where we do a transthoracic echocardiogram. TT is a transthoracic echocardiogram. And once I use these three pillars, and if I'm having a high suspicion of a case of ACS, my initial management is going to be something which is extremely important. And in my initial management, I will be giving this mnemonic is something which is not my mnemonic. It's an age-old mnemonic. It's called the MONA BC. And in MONA BC, we have M for morphine, O for oxygen, N for nitroglycerin, A for aspirin, B for beta blockers, and C for anticoagulants. I do not want to detail much on this because this again becomes a part of treatment that we do in the emergency departments. But one thing I can clearly tell you, morphine and nitroglycerin are both given in order to reduce the pulmonary edema, to reduce the preloads so that the load on the heart is reduced. Oxygen is only used if the saturation on presentation is below 92. And aspirin is something which we know is a COX inhibitor. Beta blockers, you should be very careful with it. They will control the heart rate. They will make sure that there is cardioprotection, but please make sure that there is no evidence of acute heart failure symptoms, because if the patient has come to you in ACS with an acute decompensated heart failure, you are absolutely going to crash the patient if you're giving beta blockers. And C for anticoagulants form a very important role. High smokings. But what will happen is it will involve usually the major trunk of a coronary vessel, leading to a total obstruction. And due to this total obstruction, there will be so less time that collateral supply will not be something that will be established. Usually, when if you have this idea of going through a jammed traffic, if you have the main highway which is having say 100 cars, you would usually find your way out to take a different road through the diversion, and probably take a muddy road rather, or maybe not a pakka road. You'd rather take a kacha road and move around so that you can divert the main traffic of the highway. But what if suddenly an accident has happened on the highway, and acutely in a span of 5-10 minutes there are 100 cars? It will be literally impossible for you to find that diversion way out to bypass that traffic. Collaterals exactly are similar to finding your way out to your destination by diverging or by diverting yourself from a jammed highway. So whenever there's an acute occlusion, the time for development of collaterals is almost not possible, which is why there is a single vessel disease, less collaterals. It's a more severe case where it's coming with rest pain, and because it is so if you remember, the heart, the coronary supply is usually from the endocardium to the epicardium, right? And the depolarization is exactly happening from the epicardium to the endocardium. So whenever there's an epicardium to the endocardium depolarization vector which is happening, what we usually see as the electric potentials on the ECG, what happens whenever there is an acute thrombus, whenever there is an acute occlusion, is there is going to be a transmural infarct. Because of this acute thrombus, acute occlusion, and no collateral supply, there's going to be a transmural infarct. Because of this transmural infarct, all the layers of that certain place of the myocardium is going to be involved. The epicardium, the endocardium, the myocardium, each layer will get involved along that specific territory of the vessel that is occluded. This leads to a sustained ST elevation more than 20 minutes. Leads to my second point, which is to be highlighted. Whenever I'm talking of a STEMI, that is a ST elevation MI, I am predominantly meaning that there has to be a sustained ST elevation on the ECG. And what do I mean by a sustained ST elevation? It is an ST elevation which is more than 20 minutes. Okay. Now, how do I know that it's an MI? Anytime there's an MI, be it a non-ST elevation, be it a ST elevation, one thing that will be positive is the cardiac troponins. So the troponins are going to be positive. The goal of my treatment is to remove this thrombus and to reperfuse the vessel. The moment I'm removing this thrombus, this vessel is now open and there is complete reperfusion which can be established. So my goal of therapy is predominantly a reperfusion therapy. When I talk of NSTEMI, which is a non-ST elevation MI, I'm usually meaning a patient who is kind of old, has been having multiple comorbids over quite a long period of time. And because of this chronicity, there's development of a lot of collaterals. Because of this collaterals, there is no specific place of the heart which is ischemic. There are multifocal points of ischemia, and they are kind of being, maintained by, although they are being maintained less than what usually a normal heart would, but they're kind of being maintained by a sufficient collateral circulation. Hence, it is a multivessel disease with more amount of collaterals. The pain can be at rest. The pain can be a new onset pain. That doesn't matter really. But one thing that is very clear is there is no ST elevation. A very common misconception that I found with my juniors predominantly is whenever they hear of ST-MI, they feel it's ST elevation. When they hear it is N-STEMI, they feel there is ST depression. No, my dear, no. N-STEMI can come with even a normal ECG. So please don't say that N-STEMI means ST depression. What I only need to see on the ECG is whether the ST segment is elevated or the ST segment is not elevated. If it is elevated, it is STEMI. If it is not elevated, it is N-STEMI. If my other clinical features are matching into my picture. So don't think that N-STEMI is ST depression. It can be no ST elevation. That's it. Okay. The troponins are going to be positive. As I said, any MI will have a troponin positivity. The goal of my treatment will be to reduce the thrombus formation, because this thrombus is building up with time chronically. I'll have to give anticoagulation therapies so that the thrombus production and the thrombus formation inside the vessel is slower down. Reperfusion is not the goal because it is not an acute occlusion. There is still some flow maintained in the vessel. The features of N-STEMI is very, very, very similar to unstable angina. The only difference, and the predominant difference, being that troponins are going to be normal in case of unstable angina. As I repeat, troponins are going to be normal. Normal troponin rules out an MI. Again, normal troponin rules out an MI only when the other diagnoses have been established. So one thing that I want to say, STEMI and STEMI troponins are positive. Unstable angina, usually the troponins will be negative. If the troponins are positive, it clearly means significant amount of muscle ischemia and muscle necrosis have happened. In unstable angina, there is ischemia, but the necrosis has not happened. And what do I mean by necrosis? It means that this is an irreversible piece of dead tissue of the myocardium, which cannot be reverted back again. Please remember, hence, time is muscle. The 1 minute that you lose in treating this patient or diagnosing this patient or referring this patient, you are predisposing this patient to having a muscle ischemia and necrosis, which is never ever going to be reverted again. So my goal of therapy here, as I said, is reduction of the thrombus formation. And if I talk of mortality, the early mortality within the first month, usually STEMI cases being much more acute, they have a larger vessel distribution, larger territory distribution. Hence, STEMI mortalities are much more than N-STEMI or unstable angina. But in the late cases, I mean, after 1 month, honestly speaking, STEMI, N-STEMI, unstable angina all carry similar mortality levels. Okay. Now comes to my next slide. So this was the slide. Just give me a moment. I think there's some lag in my laptop. I'll just try to fix it. Yeah. So this is the pathophysiology that I was talking of. You can very clearly see on the first image on the left side, there's a normal blood flow through the lumen of the artery. Below it, there's an N-STEMI, where you can see that some flow has been maintained through the blood vessel. And the bottommost picture is a complete or a subtotal occlusion, where there's barely any flow which is happening through that clot. A thrombus. What happens in STEMI is usually not just the thrombus. Over the thrombus comes, usually there's a plaque which is created due to atherosclerosis, due to aging, where you have a lot of lipid cells, macrophages, which come in, and they are lining the blood vessels and usually causing a decrease in the lumen already. Whenever this plaque is rupturing and whenever this plaque is ulcerating, that is exactly when platelets come, and platelets are sitting over that plaque, and that is exactly what is leading to this thrombus. And because of this thrombus, if it is a total occlusion, we usually get symptoms of STEMI. The right-sided image clearly shows how there is a transmural infarct that we get in cases of STEMI, and a subendocardial or a localized ischemia that we get in cases of an NSTEMI. So what I basically need to see in an ECG is the STI segment elevated or not elevated. That's the only thing that I need to focus on. Now, just give me a while. So as I say, what to look for? My first thing, as I said, I'll only look at two things. Is my ST elevated? Is my ST not elevated? When I say not elevated, it can be depressed. It can be a T-wave inversion. It can even be normal. So one statement, can I make this? Can I have all of your answers, whether it's a true or false? Normal ECG does not rule out an ACS. Am I right? A normal ECG does not rule out an ACS. Can I have the chats? Can I have you all saying whether it's true or false? I have an answer. Yes, yes, true, true. Exactly. So again, coming back, a normal ECG is never going to rule out an ACS. Please do not think that ECG is the only guiding tool. ECG is just a piece of paper. A piece of paper cannot override your clinical judgment. It cannot override your clinical judgment. If I have an ST elevation, one thing I'm damn sure of, this is a STEMI. This needs urgent reperfusion. It's an acute case. It's a bad case. If it is a normal chest X-ray, if it's a normal ECG, but the patient is having a chest pain, which is very suggestive of ACS, the patient is having, say, hypotension. I mean, I'm just asking you. Suppose a patient has come to you. This patient is say 35, 40 years of age. He's a gym freak. And I'm saying this, which is a case that I personally encountered in Hyderabad at some point of time. So this patient had come to me, was 35, 40-year-old guy. He was a gym freak. And I still remember, you know, he was sitting and just telling me, he was complaining of a substernal chest pain. And we did the ECG. The ECG was normal. When I was checking his pulse rate was around 120, 130. He was sweating. We were in the AC. He was sweating. And his ECG was normal. So what do you think? I'll leave him. I'll say, no, you're fine. Perfectly fine. So anytime you have to think that whether my clinical judgment is something which is something I need to trust more. I cannot trust a piece of paper. I cannot trust a report. I have to always rely on my clinical judgment. So my first statement, a normal ECG does not rule out an ACS. Now comes the biomarkers. What do biomarkers signify? They indicate cardiac injury. Usually, as I said, we have higher sensitivity troponins today. So this entire concept of troponin I, troponin T, CK, MB, everything is gone. Nothing exists in the current practice. Theoretically, you may have a lot of things asked in your exams, but trust me, in practice, we only have high sensitivity cardiac troponins. We have nothing else. Now, if you are asked about what is the earliest marker, you can give an answer, which is FABP, that is heart fatty acid binding protein, or IMA, which is ischemia modified albumin, where you can see that it is rising within minutes to hours. It attains a peak between 4 to 6 hours and dies between 12 to 20 hours. But these are very theoretical. Trust me, in modern practice, you have so much highly sensitive cardiac troponins that they will actually give you a report. But when I talk of troponins, you can clearly see this. The initial rise takes 2 to 4 hours. It peaks between 24 to 48 hours and dies down by 7 to 10 days, which clearly means if a patient has come to me in the OP or the clinic or the emergency with a chest pain which was never there before, he says, this is my first episode of chest pain and it has been there for the past 20 minutes, doctor. I live nearby. I heard your webinar one fine day. I heard such a sign of chest pain may be a sign of ACS. I'm not a doctor. I've come to get evaluated. I find that his ECG is normal. And because he's come just with 20 minutes of chest pain, do you agree with me that the troponins will be negative? Can I therefore say that a troponin being negative also does not rule out an ACS? Can I make this statement? A normal ECG does not rule out ACS. A normal troponin does not rule out ACS. Can I make that statement again? Can I have the chats on, please? Everyone in sync with me? Normal ECG does not rule out ACS. A normal troponin does not rule out ACS. So why I'm doing this, you know, I'm literally spoon feeding you this because we are so used to feeling this. Because this is something which I did back in my internship. Okay, ST not elevated, fantastic, patient is fine. Even if I'm having suspicion, you know, I used to think, okay, but the ECG is fine. The troponin is negative. Nothing overrides your clinical judgment. Yes, it may or may not come positive. If you have presented early within 10-15 minutes of chest pain, you will never get a troponin positivity. You may never get an ST elevation. Okay? Clear? Everyone in sync with me? Fantastic. Okay. Now, one thing which I'll clear off regarding the troponins, that is this table, which is below. So one thing that we say, if you are having a high clinical suspicion of chest pain, which is suggestive of ACS, you will admit the patient. Trust me, in India, most patients will literally tell you, कुछ नहीं हुआ है डॉक्टर साहब, आप ऐसे ही ले रहे हो, आप ऐसे ही मुझे एडमिट कर रहे हो. But no, you have to explain the patient that look, uncle, sister, brother, anyone, you need to explain them that look, this symptom of yours does not look good. It is your duty, it is our duty as a physician to explain them. The patients will be irritated, the patients will be frustrated, the patients will be demanding to know why you are admitting. It is our duty to keep our head cool. It is our duty to explain why we are admitting. So anytime you have a clinical suspicion of chest pain, even if your troponin, even if your ECG is normal, you will admit this patient and you will do serial monitoring. So serial ECG monitorings being negative and serial troponin monitorings being negative may rule out an ACS. Am I right or am I wrong? Serial ECG monitorings being negative, serial troponin monitorings being negative may rule out an ACS. Am I right or am I wrong? Perfect, perfect. So yes, you need to admit this patient. You need to do serial troponin monitoring. If your initial troponin level is negative, after 3 to 6 hours, again it is negative, you can kind of say that yes, there is no evidence of an acute myocardial injury. Ischemia may be there, but injury is not there. If your initial troponin is negative, I mean, if the patient is presenting within 15 to 20 minutes, you will have a negative troponin levels. But, after 3 to 6 hours, if you find that the troponin is positive, that is where you infer that, yes, acute myocardial injury is present. And what if your initial presentation is positive? After 3 to 6 hours, it is still positive. How do you understand whether this has increased, whether the injury has increased or not? You check the values. If there's a more than 20% increase in the values between the first and the second value, you say that there has been an acute myocardial injury which is progressing. In fact, this is the very parameter that we use as a test of reinfarction. I'll just give you a case which I encountered in my internship as a case of reinfarction. There was a 70-year-old diabetic hypertensive male who was admitted with a case of chest pain, exertional dyspnea, and he was diaphoretic. He was sweating. He was having a BP of around 180 by 110 on admission, if I'm not wrong. I had seen this patient on a Wednesday evening. We had started all the adjunctive therapies to him, and he was maintaining well. And because he had presented late, we could not reperfuse. We had to just do thrombolysis. We did thrombolysis. The thrombolysis was kind of successful, and the patient was doing well. We had still kept him admitted in our medicine ward. 4 days later, when we were kind of preparing, okay, we'll discharge him by the 5th or the 6th day. Fourth day eve, night around 11 p.m. when I was just going back from my hospital to my hostel where I used to stay, I find this patient suddenly having literally sweating as if he would fill a bucket of water. Literally, that is the amount of sweating that he was having. Severe breathlessness. There was no chest pain, but this patient kept on complaining that I feel I am gasping, I'm suffocating. The chest was filled with crepes which were not there before. This was new onset crepes. And when we did the troponin levels and we checked it qualitatively and quantitatively, we found that there was more than almost 50% rise in the troponins from the 2nd day to the 5th day, which means this is a case of reinfarction. So maybe there was another infarct that was developing in this patient, which again needed thrombolysis. Which is why I always say thrombolysis is actually not the best form of treatment. It is reperfusion, but thrombolysis is the only go-to if you're either having an end STEMI or if you're presenting with a late STEMI. That becomes the only go-to options. So I remember this case very vividly because we had to take this patient up right at that point of time. And by the next, half an hour, 1 hour, we had to get this patient thrombolized. And luckily, he made it. He made it pretty well after that 4-5 days of hospital stay, and he went back pretty hale and hearty and healthy. So yeah, anytime you have a case of reinfarction, again, your marker is troponin. There are a few biochemistry books for my juniors who are studying, which will say the marker of reinfarction is CKMB. But please trust my word on this. It is troponin, and it is troponin. You will just see whether there is a more than 20% increase from your last value of troponin to the current value. If there's more than 20% increase, you can be damn sure this is a case of reinfarction. Am I clear with this? Now, what are the imaging categories that we have? In the imaging categories, all I have is I have a non-invasive form of imaging, which is echocardiogram, and the another option that we have today, which is coming up very much these days, it is CTCA, that is CT coronary angiogram. I have an invasive method in the form of coronary angiogram as well. Most commonly, however, performed is the TTE, that is the transthoracic echo. And in echo, what am I actually looking for? I'm looking for something which is called RWMA, regional wall motion abnormalities. What does it mean? It means either hypokinesia or akinesia of the ventricles. Either my ventricles are not contracting very much, or they are contracting, either they are very contracting not at all, or their contraction is very limited. That is what we call as hypokinesia or akinesia. Okay, so let me just show you. I think I have got this with me. Yes. So I need an active response from you. Are you all able to view this GIF? Are you all able to view this GIF? Yes. Okay. How many of you have seen an echo done before, or you know how to interpret an echo? How many of you? And people who do not know how to interpret an echo, you can just write no, because I'll help you out in that as well. Don't worry. Okay. A few yeses, many no's. Okay, no issues. Okay. So let me just show you the basics. Are you all able to see me? Is
Yes,
my
doctor.
video visible?
Yes, doctor.
Yes, fantastic. Okay. So in this, can you see one thing? This part of the ventricle, this part which I'm marking with my arrow, can you see this part of the ventricle is not contracting as well as the other parts? Can you see this? Can you see? Also, even if you see this, can you see this part of the ventricle is contracting? However, the one that is marked with the red shade is not contracting at all. Is this very visible? Is this visible? Can you see a clear discordance? In the first image, in the first GIF, you can clearly see that there is a limited contraction. And in the one that is below, where I have written there's a proximal LAD STEMI with anterior wall akinesia, can you see that the anterior wall is absolutely not moving with respect to the other parts of the heart? So yes, that is exactly what we call as RWMA when we are looking at a case of ACS. We are either looking for hypokinesia or we are looking for akinesia. Okay? Now, a very general question which is needed to be addressed right here. As I said, an ST elevation will make you think that this may be a STEMI. But are all ST elevations STEMI? Are all ST elevations STEMI? For example, I'll ask you a question. I want this answer in the group. Suppose a person who is, say, 42-year male has come to you in the OPD with a case of master health checkup. You know, this hospitals today are going for master health checkups where you're having a full body checkups being done. A 42-year-old male comes to you for evaluating his reports of master health checkup. He has absolutely no issues. He's walking into your room like a fit chap, and he's saying, doc, I've done all my reports, and you find a very mild ST elevation on his ECG. Will you call it as a STEMI? Okay, no, very good. I'm waiting for a few other messages. Yes, no, very good. Very good. Fantastic. So yes, as I said, your clinical judgment is something that is going to be never overridden by a piece of paper. So a person who is hale and hearty walking into your OP is jumping around, he's having a very mild ST elevation, you cannot call it STEMI. Leads to my second point. Just like, so I'll repeat my take home messages that we did in the earlier slides. My first take home message was, a normal ECG does not rule out an ACS. A normal troponin does not rule out an ACS. Can I ask one question to you all? A normal echo rules out an ACS. True or false? A normal echocardiogram rules out an ACS. True or false? Everyone in the chat. A normal echo rules out an ACS. True? Okay. Somebody saying true. Somebody saying no. Okay. A few more answers, please. Okay. Okay. So when I was talking of ACS, do you realize that I talked of unstable angina, I talked of STEMI, I talked of NSTEMI as well. Akinesia and hypokinesia will develop only when a significant part of the myocardium has been necrosed. Unless a significant part of the myocardium has been necrosed, that part of the wall will not show hypokinesia or akinesia. So are you thinking that you will be waiting for the echocardium? You'll be literally waiting for this patient in chest pain for almost 30-45 minutes without giving him any treatment so that you want to see RWMA changes on echo? Is it? I'll talk of angio a little later. Are you getting me what I'm saying? Are you getting what I'm trying to say? Will you be waiting for this patient? Will you be saying, no, I need to see RWMA. I'll not give you treatment. So once you start treatment, do you realize that the amount of muscle necrosis and the myocardial injury will start going down, right or wrong? Am I right or am I wrong? The moment you start giving treatment, yes, fantastic. The moment you start treating this patient, and the earlier you treat this patient, the muscle injury will be less, the myocardial necrosis will be less, and you will be having a case where you will not find RWMAs on echo as well. Am I right or am I wrong? So can you all sitting in your homes at this point of time or wherever you are, yes, echo will give you more information, but what I'm trying to tell you, Dr. Twinkle, is a normal ECG does not rule out an ACS, a normal troponin does not rule out an ACS, and a normal echo does not rule out an ACS. As Twinkle correctly said, there may be some times when the ECG is looking normal, when the okay, let me give you another example. Suppose a patient is already a case of CAD. A patient is already a known case of heart attack. He is a known case of coronary artery disease. He has had a heart attack in 2015. He has had an episode of MI in 2015. And although he was thrombolized, but a significant part of muscle necrosis happened. So do you realize that that part of the ventricle will already be showing akinesia and hypokinesia? Am I right or wrong? Even if you see it in 2015, 2025, 2035, as long as he's alive, because a significant amount of muscle necrosis happened in the year 2015, those parts of the ventricle will still look akinetic and hypokinetic. Am I right or wrong? Right. Yes, perfect. Now say in the year 2025 today, he comes to me with a new onset of chest pain in the similar territory of his earlier chest pain. Maybe the same artery got involved again. Can you on the echo diagnose whether this is a new hypokinesia or akinesia? Fantastic. That again shows that a normal echo or a no change in echo does not rule out an ACS. Am I clear now? Am I clear? Is my statements clear? Are my statements clear now? That a normal ECG does not rule out an ACS, a normal troponin does not rule out an ACS, a normal echo does not rule out an ACS. That's the fun part of learning, that nothing normal rules out an ACS as long as my clinical suspicion is continuously telling me that this looks to be a bad chest pain. Okay, clear? Fantastic. Okay, thank you all for being so active today. Okay, so leads me, every ST elevation is not a STEMI. So what are the different differential diagnoses for ST elevation? The first one being a Prinzmetal angina. When I talk of Prinzmetal angina, it is not due to a thrombus or a clot. It is mainly because of a vasospasm that has been occurred in the vessel. Some coronary arteries of some patients have usually much more vasoreactiveness. They have more tendency to become vasospastic than the other patients. So these usually happen to be, heavy smokers in their 50s or 60s. And mainly it's the right coronary artery which becomes vasospastic, as you can see in this image. There'll be chest pain, there'll be ST elevation, but the coronary angiogram will be normal. So somebody in the group at some point of time, I think a couple of minutes back, was talking of coronary angiogram. No, even a normal coronary angiogram does not rule out an ACS. Is this particular example of Prinzmetal angina enough to clear that a normal CAG does not rule out an ACS? Am I right? So can I now say the four statements? A normal troponin does not rule out ACS. Normal ECG does not rule out ACS. A normal echo does not rule out ACS. Even a normal coronary angiogram does not rule out ACS. I am telling you of an entity which I did not add here in this slide. It's called Minoca. I can just type this. It's MINOCA. Just wait. It's MINOCA. I want you all, this is a homework. I want you all to read a bit about it. It's called Minoka. So I want you to read about Minoka. When you read about Minoka, you'll actually understand that even patients with ACS-like symptoms, typical ACS-like picture, but having a normal coronary angiogram. Okay? Everyone in sync with me? So these patients of Prince metal angina are something that you will be diagnosing mainly on, vasoreactivity testing, provocative testing. Either you give them acetylcholine or, on hyperventilation, their symptoms are precipitated. There may be some vasospastic drugs like cocaine, like 5-fluorouracil, which can be leading to ST elevations. There can be acute pericarditis. There can be left ventricular hypertrophy, left bundle branch blocks. Hyperkalemia, hypercalcemia can lead to ST elevations in the ECG as well. That may mimic a STEMI, but it is not a STEMI. How do I know that these are not STEMI, but STEMI mimics? So in STEMI, do you realize that, okay, let me just see myself once in the video. Just give me a moment. Yeah. So do you realize if what is in front of me is a camera, suppose this is the camera which is recording my electrical activity, do you realize that if I have a vector towards the camera, it will show a positive deflection? That's what an ECG principle is. Any lead which records a vector which is towards it will give me a positive value. Any lead which records a vector away from it will give me a negative deflection. Everyone knows this? It's a basic concept. Everyone aware of this concept? A lead which is showing, yes, I'll repeat the normal CAG wala part. So as I said, there's something called Minoka. There's something even in cases of Prince metal angina. In Prince metal angina also, you will get a case where coronary angiogram is going to be normal. So a normal a normal CAG does not rule out an ACS. Prince metal angina patients will come to you with features typical of ACS, and if you do not treat them with calcium channel blockers, you're actually going to lose them very fast. Okay? So even in Minoka patients, they're going to have a normal coronary angiogram. Now, coming to the ECG aspect, where, as I said, that all ST elevations are not STEMI. All ST elevations are not STEMI. How do I know that? So when I see an ST elevation, how do I know it's an ST elevation ME? I mean, ST elevation MI, or is it something which is an ST elevation mimic? How do I know that? So the basic concept of ECG is, if this is one phase of the heart and there's a camera which is recording me, any vector which is directed towards the camera will deflect positively. Anything which is deflected away from the camera is deflected negatively. Am I right or am I wrong? Anyone who knows this? Everyone is aware of this? I clearly say this in a very simple way. I say this: if a beautiful lady, if a beautiful girl is coming towards you, you smile and you become positive. So you have a positive deflection. I mean, mentally a positive deflection. And if the beautiful girl is going away from you, you tend to get depressed, and that is when the lead records a negative vector. Am I clear with this? This is a very basic understanding. Yes, very good. So now, if this part of my myocardial wall is getting ischemic and necrosed, do you realize that the current that is directed here will show a very high positive elevation as a STEMI ST elevation, and the lead which is exactly directly opposite to this will see this beautiful girl going away from it, so will record a reciprocal ST depression. Am I clear? Am I clear with this concept? Everyone? If this part of my myocardium is necrosed and here's the camera, it will record a current injury, which will give me an ST elevation, whereas the camera, which is directly opposite to this, behind me probably, will record it as a negative deflection. So there'll be a reciprocal ST depression in the leads which are exactly opposite to the current of injury. Am I right or am I wrong? Fantastic. So this much is clear. So anytime I have to rule out whether it's a STEMI or a STEMI mimic, my only thing to see is, please see if there's a reciprocal ST depression in the other leads which are just opposite to the ones where you're getting the ST elevation. If that is fulfilled, you can clearly say it's a STEMI. Otherwise, you will just consider it that probably it's a STEMI mimic based again on the picture of presentation. I repeat, your clinical presentation is the main thing that will guide you towards your diagnosis. Am I right? Am I clear? Am I clear? Are you all comfortable with this? Everyone's comfortable with this? Fantastic. Okay. Now, so this slide particularly is the IC only what the mind knows. So when I say this, what you will be expected to know is the basic coronary anatomy. When I talk of the coronary anatomy, One is, this is the right coronary artery, and from the right coronary artery comes down the right marginal artery, which is going to supply the base of the right ventricle. And here is the main trunk of the left coronary artery, which is giving rise to the main trunk of the LAD, which is the left anterior descending artery, which is supplying mainly the anterior part of the left ventricle, the septal part, the anteroseptal part, the apical part of the left ventricle. And from the LCA comes out another branch, which is the LCX, which is the left circumflex artery, which is turning around the anterior part and is going backwards behind, meeting the right coronary arteries division, and it is then anastomosing to the posterior part of the ventricles, right? That's the basic anatomy that we know. So one thing that we are very, very clear is, when I talk of the slides, I mean the ECG leads, if you can see the ECG leads, this is the 12-leaded ECG, the V1, V2, V3, V4, V5, V6, V7. If you arrange them very clearly in order, can you very clearly now understand that you can localize exactly where the ischemia or the necrosis is? So when you are seeing an elevation in lead 2-3 AVF, in lead 2-3 AVF, do you realize it is the inferior part of the heart which it's seeing? Can you see that these cameras are basically seeing the inferior part of the heart? And in the inferior part of the heart, what is the culprit artery? What is the culprit artery in the inferior part of the heart? When I'm talking of inferior part of the heart, mainly, can you see from this anatomy, it is mainly the right coronary artery which is going down as the right, as the right marginal artery that's supplying the inferior part of the heart. Also, there's something called a posterior descending artery or the posterior interventricular artery, which mainly is traversing along the inferior border to go to the posterior end. So anytime I'm having any ST elevation in lead 2-3 and AVF, which is mainly involving the lower lower border of the heart, the inferior walls of the heart, can I call it as an inferior MI? Please do not call it as an inferior wall MI. It's an inferior MI. And inferior MI, the main culprit vessel is mainly the PDA, the posterior descending artery. Based on where this PDA arises from, it can arise in most patients. It arises from the LCX, which leads to a left coronary dominance. In some patients, it arises from the RCA, which results in a right coronary dominance. Can I say this, that mainly inferior MI is due to the culprit artery, which is the posterior descending artery or the posterior interventricular artery? Am I right or am I wrong? Can I say this? Everyone, I'm actually following all your chats. Okay, fantastic. Very good. Now, mainly it is due to the RCA, mainly because the PDA mainly is arising from the RCA. Okay. Now, I want you to focus on this lead called V4R. Now, what is V4R? Most of my juniors who may not be aware of V4R. Now, usually, if V4 is what we place on the left side here, this is where we place V4. इसी लीड को उठा के राइट साइड में प्लेस करो. The same V4 lead, if I'm putting from the left side to the right side, that becomes a V4 right-sided lead. Am I right? Am I right? Now, if I see V4, if you clearly see this image, where is V4? Yes, here on the left side. If you swap this lead of V4 to the right side, can you clearly tell me that, can I now say that this V4 will actually be showing the right ventricle of my heart? Am I right or am I wrong? If I swap the V4's presentation from the left side to the right side to make it a V4R, can I say that it will show me the right ventricle of my heart? Can I say that? So anytime there's an ST elevation in V4R lead, can I say that it's a right ventricular MI? Can I say that? Fantastic. Okay. Again, V4R, right ventricular MI, which is the artery which is supplying the right ventricle? Everyone in the chat. Which is the artery which is supplying the right ventricle? See the picture. You have the anatomy. You have the anatomy which is there. Which is the artery which is supplying the right ventricle? Please feel free to answer, even if you make mistakes. Yes, it is the right coronary artery. It is the right coronary artery. Fantastic. It is the right coronary artery or the right marginal artery. Yes, it's a branch of the RCA. Correct. Fantastic. Now, so we are done with inferior MI, it's 2-3 AVF, and we are done with inferior MI and the culprit vessel being PDA, which is mainly from the RCA than the LCX. We are done with V4R, which is the right ventricular MI, and the main culprit artery is the RCA. Now let's see this V7, V8, V9. Where is V7? Where is V8, V9? We do not have V7, V8, V9 here. Now, in this picture, we do not have it. But what do we exactly do? If I tell you V1, V2, V3, I place all these leads, V1, V2, V3 jahan pe hai, I take these leads up, open this from here and place it exactly behind the heart. V7, V8, V9 is exactly the posterior representation of V1, V2, V3. I repeat, V1, V2, V3 are here. This is V1, this is V2, this is V3. I take all these leads up and I place it here, posterior part of my heart. That becomes V7, V8, V9. Am I clear? Am I clear? So if I find that there is a ST elevation in V7, V8, V9, can I say that it is a posterior MI? Can I say that there is a posterior MI if there is a V7, V8, V9 elevation? Can I say that? Anyone who's not understood this V7, V8, V9, anyone who's not understood it can tell me. Anyone who's not understood this V7, V8, V9. Everyone is clear with V7, V8, V9? Everyone? Perfect. So if V1, V2, V3, again, V1, V2, V3, I pick this up, put it piche ki taraf. My heart, I'm seeing it from behind. That is V7, V8, V9. When I'm placing V7, V8, V9 behind and I'm seeing that there's an ST elevation there, can I say it's a posterior MI? Correct. Now, yes, where does it appear? We don't have leads. Very good question. Usually, when we place the standard chest leads, do we place V7, V8, V9? Do we place it? Do we place V7, V8, V9 on a standard ECG lead? No, right? How do I understand that there is a posterior MI then? Kaise pata chalega? So, do you realize posterior MI ka culprit artery kaun hai? Who is the culprit artery of the posterior MI? It is again a right coronary artery because it is the major trunk of the posterior interventricular artery which is supplying the posterior part. Am I right? Am I clear when I say that the posterior interventricular artery is supplying the posterior part of the heart? And posterior interventricular artery is a branch of RCA or LCA? RCA, fantastic. It's a branch of RCA. So can I say inferior wall MI, RV MI, posterior wall MI, all involve the main vessel, which is RCA. Am I right? Am I right? Exactly. Now, see the beauty. If I have a 2-3 AVF ST elevation, can I say that it is an inferior MI? Can I say it is an inferior MI? ST elevation in 2-3 AVF. Okay, we have an inferior MI. Whenever we have inferior MI, my predominant vessel can be RCA or LCX, correct? If it is RCA, it also has to involve some parts of the right ventricle or posterior leads. But I do not have posterior leads. So if at all I had V7, V8, V9, I would have seen ST elevation in V7, V8, V9. But what did I teach you? Sometimes if I do not have a lead in front of me, I will look at the reciprocal changes just behind or diagonally opposite to that lead. Do you remember it? Do you remember? I had said this, I need to look at the reciprocal changes exactly opposite to that lead. So can I say that if I really want to localize a posterior MI, which should have come with an ST elevation in V7, V8, V9, I am not actually placing V7, V8, V9, but what is the reciprocal equivalent of V7, V8, V9? It is V1, V2, V3. And in V1, V2, V3, I will be finding ST depression with a tall R wave. Can I say it? क्योंकि अगर if I had placed it V7, V8, V9, I would have found ST elevation. Because I'm not keeping it there, I'll find the reciprocal ST changes. That is V1, V2, V3 mein, I will find ST segment depression. Am I right or am I wrong? Anyone who's not clear with this concept? Anyone who's not clear with this concept, I'm ready to demonstrate it even on my body. Is this clear? Because I really want you to be very clear with this. Okay. Just for you to understand, I'm just saying this again. If you can see me very clearly, this is V1, this is V2, this is V3. These are the exact equivalents that I'll place behind me. Because I cannot place them behind, if I have a posterior MI, there would have been an ST elevation in these leads. Because I'm not having these leads, I'll find a reciprocal ST depression in my chest leads V1, V2, V3. Am I clear? Is this very, very, very clear? Fantastic. Thank you. Thank you so much. We will be recollecting this when we see ECGs. I have a lot of ECGs to show you. I want you to be patient. Okay? I'm so glad that today is one webinar when nobody is talking of when will this end and when will I get my certificate. And I'm so glad to hear all of you. Thank you. Thank you so much. Okay. So are you all with me? I hope nobody's getting bored. Nobody's getting bored. Fantastic. Thank you. Thank you so much. Okay. So now we have done the difficult parts. Okay? What was the difficult part? Localizing the right coronary artery tracts. So I know one thing. Anytime I have a right coronary artery or its branch, it can either lead to an inferior wall MI, inferior MI. I can lead to an RVMI. And RVMI, how will I see it? Via V4R. V4 is here. मैं उसको उठा के यहाँ लेके आऊंगा. It will be a V4R. And anytime I need to see a posterior MI, it will be a V7, V8, V9 ST elevation. But if I don't have it, no worries. I'll see a reciprocal ST depression and a tall R wave in V1, V2, V3. Am I sure? Am I clear? Do you also know this, that normally the R wave should be very short or even not present in V1. The height of the R wave should keep progressing from V1 to V6. How many of you know this? The height of the R wave should keep on progressing from V1 to V6. Do you know this? Okay, you do not know. Okay, so just see this image. Just see this image. Can you see where V1 and V6 are? Do you realize that the first part of the heart to get depolarized is actually the septum? The septal depolarization happens first. So when the septum gets depolarized, which are the leads which will show the vector? V1 and V2. Can you see V1 and V2 are exactly near the septum? Am I clear? Are you all able to visualize with this? Are you all able to see the slide and visualize that V1, V2 will show me the septal depolarization vector? Perfect, perfect. Now, I will gradually move my depolarization vector towards the main part of my left ventricle. That will be the anterior walls. And that is exactly where V3, V4 will start coming in. So can I say that the depolarization vector is now moving gradually from V1 to V4 and onwards? Can I say that? Now, it's your duty to tell me which is a more bulky muscle. Is the septum bulky or the left ventricle का पूरा myocardium bulky? कौन ज़्यादा bulky है? Who is more bulky? Which is a bulkier muscle? Is it the septum which is bulky or the left ventricle which is bulky? It is the LV bulky. So which will produce a stronger vector? Will the LV produce a stronger vector or the septum will produce a stronger vector? LV will produce a stronger vector. Very good. Now, these vectors are like pretty girls. Are the pretty girls coming towards the V1, V2, V3, V4 leads, or are they going away from the V3, V4 leads? Are the pretty girls coming towards the... No. Somebody was saying away. Please check. Dr. Geetika, एक बार अच्छे से देखो. Please see the depolarization vector of the ventricle. Beta, not the septum. The depolarization vector of the ventricle, is it moving towards V4 or is it moving away from V4? Geetika, this is not to single you out, beta. This is to help you understand. Geetika, you understood? Fantastic, beta. So beta, if you see this clearly, the V4 vector, the V4 lead, the V3, V4 leads are seeing the ventricle wala vector directly. It is like the beautiful, the prominent, beautiful girl. It's like say Deepika Padukone is coming towards V3, V4. Will they smile? Will they smile, Geetika? Will they have a positive vector, Geetika? Correct. They'll have a positive vector. Once they have a positive vector, can I say that the tallest R wave will actually be found in V3, V4, V5 rather than V1? The only chotu sa R that V1, V2 will record is the septal depolarization. Gradually, the height of the R wave will start increasing because the bulk of the muscle depolarization vector of the left ventricle is going to come here. Am I clear? Yes, Dr. Rajeshri, I'm going to repeat this again. I'm going to repeat this. So, I'm going to repeat this. Just give me a moment. Yeah. So, can you look at me? Can you look at me? Yeah. So, I'm the camera. Okay, I'm the camera. I have V1 here, and this is the septum. The septum depolarizes. It's a small piece of muscle, and V1 records a positive lead. The V1 records a chotu sa positivity because it's a small muscle depolarizing. Now, V1, V2 are recording the positive chotu sa chotu sa R positive deflection. That is because of the septal depolarization. Now V3, V4, V5, they are facing the bulk of the depolarization vector of the left ventricle. The left ventricle being more bulky and a stronger muscle, it's going to send a larger depolarization current. Do you agree? V4, V3, V2, and mainly V3, V4, V5 will be recording a taller R positive deflection because of the depolarization of the left ventricle. Am I right, Dr. Rajshri? Am I right? Dr. Aritra? Dr. Rajshri? Dr. Adarsha? Am I right? Everyone's clear? That, I repeat, V1 to V4, the R wave, basically, my summary of what I said is V1 to V4, the R wave will basically start increasing in height. Because in V1, you'll have a small R wave, V2 also you'll have a small R wave. This positive deflection is because of the septal depolarization. But after the septum is depolarized, it is the left ventricle mass which is bulky and that is depolarizing, which will move towards V3, V4. So they will show larger depolarization vectors than V1, V2. Am I clear? Itna clear is sabko? Everyone is clear with this. So can I say that the tallest R waves will actually be found in V3, V4, V5 and not V1, V2? Can I say that? Fantastic. Now think, if I'm having a tall R wave in V1, what does it mean? It clearly means that there is some other current of injury which is, causing my R wave to go up. Can I say that? Can I say that? Along with it, if you have an ST depression in V1, V2, V3, can I say this, that if you're having a reciprocal ST depression, it means that exact opposite to V1, V2, V3, which was supposed to be V7, V8, V9, which is in the posterior part of the heart, should be having an ST elevation. Can I say that? And therefore, it is a posterior MI. Can I say that? Perfect. So can I, in a nutshell, say one thing? Once you know that it is a right coronary artery which is involved, your duty is to check whether it is a right coronary artery involving the inferior MI, or is it involving the RV MI, or is it involving the posterior MI? Can I say that? Because all the three MIs have one artery in common. That culprit artery is RCA. Can I say that? Which is why even a staff nurse, even an experienced staff nurse in the ICU, forget about a doctor, even a staff nurse, if she sees an inferior MI, I'm telling you, if she sees a 2-3 AVF elevation, do you know what she does? An experienced staff nurse, I'm not even talking of a doctor, an experienced staff nurse will immediately place V4R to check whether there's an RVMI, and she'll immediately place V7, V8, V9 to check whether there's a posterior MI. Is this clear? And I trust me on this, no book can teach you this, because this is only something that you learn while in clinics. Am I clear? So anytime you have a 2-3 AVF elevation and you know it's probably an RCA, you have to check whether it is just inferior or has it involved the right ventricle. For that, you do V4R, see if there's elevation, or you will check the posterior MI, whether either you place V7, V8, V9, or you see a tall R wave and ST segment reciprocal depression in leads V1, V2, V3. Am I clear? Is this entirely embedded in your mind? Good enough with everyone? Fantastic. Now the easier parts. See, V1, V2 facing the septum, so septal MI. And septum, which artery is there? It is the left anterior descending artery. Very easy. Easy peasy. V3, V4. A bit of septum, a bit of anterior wall, anteroseptal MI. We call V1 to V6, this total place, we call it as an anteroseptal wall. Okay? Because V1, V2 is septum, and V3, V4, V5, V6 mainly are involving the anterior walls. Okay? Am I clear? So can I say, if there is a total ST elevation in V1, V2, V3, V4, V5, V6, can I call it that it is a anterolateral, it's an anteroseptal MI. Can I call it anteroseptal MI? Perfect. Perfect. Now, what are the lateral most leads in that picture? Can you see the picture? The picture of the slides. Can you see that the lateral most leads are 1 and AVL? 1 and AVL are the lateral most leads. If you see the placement of the leads, if you see the placement, you will find that 1 and AVL are the lateral most leads. So any ST elevation in 1 and AVL will be a lateral MI. It is clear. Is this clear? Clear with everyone? So we have done the localizing of all the MIs now. Am I clear? छोटू सा summary, फिर we'll start doing a quiz where we'll be seeing ECGs. ठीक है? Good with everyone? Can I have some water? Can I have some water? Thank you. Thank you. Okay. So, छोटू सा summary. If you are having 2-3 AVF elevations, think of inferior MI. You have two culprits. Either it's an RCA or LCX. The only way that you can rule out whether it's an RCA is do a V4R, see if there's RV involved. RV MI hai ki nahi. Do a V7, V8, V9 or check for a tall R wave and an reciprocal ST depression in V1, V2, V3 to rule out posterior MI. Bus, your RCA territory is done. Khatam. Now, if there's V1, V2 elevation, it's septal. V1 to V6 elevation, anteroseptal. If 1 and AVL being the lateral leads have elevation, it's lateral MI. Am I clear? In cases of septal and anteroseptal, it is the LAD, the main trunk of LAD. Do you know what is the other name of this artery called? Anyone who can tell me will get a chocolate from me. Anyone who knows what this artery LAD is called. Don't give me the full form. It's left anterior descending. I'm asking you, what is this artery also called? It is called the widowmaker's artery. Anyone who knew this? Widowmaker's artery. Because the maximum cases of heart attack leading to death is because of an extensive anteroseptal or an anterolateral MI. And for all, if you see, septal MI, LAD, anterior MI, LAD, anteroseptal, LAD, only lateral MI is LCX, and LCX also is a branch of LAD only. So if there's a main thrombus in the main trunk of LAD before LCX is coming out, you will have an LAD occlusion, and LAD occlusions lead to maximum amount of deaths in this country. Hence, it's called a widowmaker's artery because mainly it is involved in males. Is everyone clear? Can I send this recorded lecture to your mail? I think this is something which the team has to talk of. I think the team does upload this on YouTube. You can save the link of it, okay, on YouTube. Are you all clear with what I explained? Are we good enough to go to ECGs? Can we try our luck on ECGs? Can we do it? Everyone excited? Okay. Chalo. Okay. Chalo. Let's do this. Before we do this, let's just solve this question. ठीक है? चलो इसका आंसर बताओ. Everyone, give me an answer to this. Giving you 10 seconds, 15 seconds. Chalo, everyone. 74-year-old man, dyslipidemia, hypertension, aortic sclerosis, has come to the ER with chest pain. The chest pain is very similar to angina attacks. He has taken 3 nitroglycerin tablets with some relief. Okay? In the emergency, he is given aspirin, metoprolol, and morphine. He is placed on nasal oxygen and ECG monitoring. The patient is diaphoretic. He appears to be uncomfortable. Is it a good chest pain or a bad chest pain? Will I relieve this patient? Will I relieve this patient? Okay, somebody has already answered. Somebody has already answered. I'm so glad. Dr. Sneha Mukherjee. Oh, Sneha is my student. Hi. Hi, Sneha. Okay, I'm getting answers. Dr. Pawan, Dr. Twinkle. Yes, yes, yes. I'm getting a lot of answers. So, why is everyone saying unstable angina? Yes, it is the correct answer. Why is everyone saying unstable angina? Why is everyone saying unstable angina? Yes, it is indeed a bad chest pain. Why is everyone saying unstable angina? ST depression and T wave inversion on ECG. Acha. Okay. What else? Normal cardiac enzymes. Okay. So somebody who said ST depression, I'm not able to read your name. Who said ST depression? Wait. Just wait. Just give me a moment. Somebody wrote ST depression. I need to read the name, which I am unfortunately not able to read. Okay. Whoever it was, it is not ST depression. Beta, the ECG looks perfectly normal. If you see this ECG clearly, there is absolutely no issues with this ECG. There is absolutely no issue with the ECG. The ECG looks perfectly normal. There is no ST elevation. There is no ST depression. Leads to my first point that a normal ECG does not rule out an ACS. Am I clear now? A normal ECG, it is not ruling out ACS. Am I clear? Do you get a proof of what I said? This patient with such bad symptoms is having a normal ECG. And the answer is unstable angina indeed, because the cardiac enzymes are normal. I clearly said that the only time that you will say that it is unstable angina is when the cardiac enzymes are normal. So will I leave this patient? V4 to V6, let me just see once. V4 to V6, ST depression and T wave inversion. I'm not getting an ST depression, beta. No, 1, 2, no, they are not ST depressions. No, they're pretty normal. So no, it cannot, it is not a case of there's no pathological Q waves, there's nothing. This is an absolutely normal ECG, absolutely normal ECG with the cardiac enzymes as normal. This is unstable angina. There's someone who asked, why is it not a stable angina? He's not a stable angina, number one, because the first thing is this patient has come to you in an unstable state with absolutely crashing vitals. In a stable angina, this patient would never land you up in the emergency, will never have a stable angina coming to you in the emergency. He would walk to you in an OP. Okay? And he clearly says that the number one. Number two, a stable angina will not have recurrent attacks. There is no stable angina which has recurrent attacks. If you see, he clearly says the question is the chest pain is similar to angina attacks in the past. He has taken 3 nitroglycerins with some relief. Even after that, he has been given metoprolol, aspirin, ACE is aspirin, morphine, and is placed on nasal oxygen. Do you feel that this patient is doing well? Do you think it's a stable angina? It is unstable angina because in stable angina, you do not have recurrent attacks. You will never have recurrent attacks. Okay? Everyone's clear with this? Everyone's clear with this? Dr. Parthasarthi? Everyone's clear? Thank you. Thank you so much. Can we shift on to the next question? Can we shift to the next question? So one question, will I leave this patient home? Will I say him कि नहीं हमने दवा दे दिया है, ECG normal है, घर जाइए? Will I be leaving this patient? Will I leave this patient home or will I admit this patient? Will I leave or will I admit? Exactly, we'll do serial monitoring and we will do adjunctive therapy in the form of Mona BC. We will give Mona BC and we will see how this patient is doing. Correct? Fantastic. So a normal ECG does not rule out an ACS. Chalo, let's go to the next one. Now, so this is your next question. Chalo, tell me. 70-year-old man has come with chest pain, noted to have 2 millimeter of ST segment elevation in the inferior leads. Systolic BP is 84, heart rate is 124. He seems alert, JVP is elevated, lungs are clear. What is the best treatment? Okay, I'm getting IV Dobute, IV NS. I'm getting majorly NS. Only one person giving Dobute. Who is this? Who is the one who's talked of dobutamine? Let me just read out. Okay, I'm not able to read your name, but okay. Everyone sure about NS? Everyone sure about NS? Okay, what is this MI? It is an inferior MI. Clear? It is an MI. Yes, it is an inferior MI. Whenever I find the case of inferior MI, and most commonly because inferior MI involves the region of the heart which is very close to the vagus nerve. The vagus nerve being involved leads to hypotension. In fact, this is the only MI where you will give fluids. Never give fluids to any other MI, because if you are giving this patient, any other patient apart from inferior MI, if you are giving fluids, be very sure you will be not seeing a sunrise without jail the next morning. That's my guarantee. Okay? And this is not to make you afraid, but this is just to tell you that do not give fluids to any patient of any other MI. You will basically be leading to pulmonary edema and heart failure, because you will be increasing the load on the heart like anything. As I said, the entire Mona BC mein jo N we are using to reduce the preload. This is the only case where we will increase the preload by giving fluids, because it is an inferior MI. Inferior MI also involves the region where the vagus is in very, very close proximity. Because of the vagus nerve being involved, the hypotension happens. Okay? Am I clear? Somebody who said dobutamine, no, beta, dobutamine is only given if I'm having a ejection fraction which is low. There is no you know, evidence that he is having a low EF. If this patient had a low EF, then I will give fluids, I will give dobutamine as well. ठीक है? I don't know who wrote dobutamine, but this is your answer. ठीक है? Clear? Everyone's clear with this? Fine. Okay. Yes, vagus nerve stimulation happens. Perfect. Correct. Okay. Let's move to the next question. Okay. ECG number 1. Can you tell me what is happening? ECG number 1. Can you tell me what is happening? I just need to know what MI it is. Nothing more. I need to know the MI and I need to know the territory. Nothing more. Yes, it is. I'm getting answers. Very good. Yes, it is MI, but I need to know what MI it is. What MI? What MI? I'm already getting answers. Yes, it is an anteroseptal, or you can clearly say it's an anterior MI, because anytime a septum is involved, anterior wall is involved, septum will also be involved. So it is anterior MI. Is this clear with everyone? I'm finding a gross ST elevation in the leads V1 to V5, V6 maybe elevation. V1 to V6, everyone is elevated. Can I say this is the case of anterior MI? Can you tell me what is the culprit artery? Can you tell me what is the culprit artery? What is the culprit artery? It is LAD. It is LAD. Yes, it is LAD. Left anterior descending, which is the widowmaker's artery. So what is my goal of therapy? I will give Mona PC and I will reperfuse. If the patient has come to me in a proper time, which I'll definitely not talk of today because it's not going to suffice in, my main target is going to be reperfusion. Correct? Am I going to do that? Perfect. Okay. Come to ECG number 2. ECG number 2. ECG number 2. Can you diagnose ECG number 2 for me? Come on, I need answers. Come on. ECG number 2 for me. Okay, I'm getting a few not so correct answers. ECG number 2. ECG number 2. Beta, the ones who are saying inferior, okay, I just found, yeah, ST elevated, I know, that's good. But who is saying inferolateral? How can it be inferolateral, beta? Beta, can you tell me ST elevations is in which segments? Just tell me the leads where you have ST elevations. Yes, I'm getting a few correct answers now. Yes, I'm getting a few correct answers. Dr. Swastik, Dr. Parthasarathi, Dr. Balaji, and few others who have given the correct answer. Dr. Twinkle, yes. I want to know which leads are you finding ST elevations in? Everyone. ST elevations are found in which leads? Which leads are you finding ST elevation? 1 and AVL, perfect. और कहीं पे दिख रहा है? The ones who were saying inferior, beta, did you find any ST elevation in 2-3 AVF? Are you finding any ST elevation in 2-3 AVF? No, AVL and 1 is not inferior. No, beta, inferior leads. Please see that picture. Heart ke niche 2-3 AVF are there. So only 2-3 and AVF can see inferior MI. 1 cannot see inferior MI. 1 is here. 1 is on the side. Idhar hai mera 1. 2-3 AVF is niche. So 2-3 AVF is going to see inferior MI. V5, V6 also has a bit of ST elevation. हाँ, ठीक है, थोड़ा सा. But majorly it is in 1 and AVL. Can I say that? Actually, V5 and V6 does not have an ST elevation. So how do we call it as an ST elevation? If the point, I mean J point se agar at least 2 millimeter if you are having an elevation only, then it is an ST elevation. Please note, V6 does not have an ST elevation. V5 also does not have an ST elevation because it is 1 millimeter elevated. V4 also does not have it. But if you see lead 1 and AVL, you will find clear ST elevations in 1 and AVL. Everyone's clear with it. 1 and AVL, you are having clear ST elevations. Look at the J point. J point से at least 2 millimeter ऊपर होना चाहिए ST elevation के लिए. You are not having that in V5 and V6. Yes. Yes, Twinkle, 1 and AVL. So 1 and AVL points to which MI? It is lateral MI. Can you tell me what is the culprit vessel in lateral MI? What is the culprit vessel in lateral MI? Anyone who did not understand why this is lateral MI? Anyone who did not understand why this is lateral MI? Anyone? Koi hai? Somebody who did not understand this lateral MI? Please repeat. Okay, I'm repeating. I'm repeating. No issues. Okay. So a few like Dr. Rajshri and a few others whom I'm not able to, read your names out. Can you see ST elevation is there only in lead 1 and lead AVL? Baki mein there is no ST elevations. Can you see that? I'll give you a proof. Wait. What is the lead which is exactly opposite to lead 1 and AVL? Matlab 1 and AVL is on the left side. Do you agree that AVR is exactly diagonally opposite to 1 and AVL? Can I say that? Can I say AVR? Can you just see AVR? Can you note if AVR is having an ST depression and a T wave inversion? Can you check if AVR is having an ST depression and a T wave inversion? So agar AVR mein you are having an ST depression and a T wave inversion, what does it imply? That this is a reciprocal change. Can I say that? Lead 1 and AVL is having ST elevation. Pakka now? And for the ones who were thinking V4, V5, V6 may you have ST elevation, what is the reciprocal lead to V4, V5, V6? Again, the reciprocal lead to V4, V5, V6. Anyone? It is AVL and 1. No. Somebody who, yes, it is AVL, correct. So in AVL, you should have found ST depression. Are you finding ST depression in AVL or ST elevation in AVL? Are you finding ST depression or ST elevation in AVL? Dr. Jayesh, yes, elevation. So does it clear your doubts now कि V4, V5, V6 में कोई elevation नहीं है? Always see, अगर doubt हो रहा है ना, अगर कहीं पे doubt हो रहा है, if you are doubtful even for a moment कि V5, V6 में elevation है कि नहीं, see the contiguous opposite lead. See if there's elevation, it will be it cannot be a STEMI there. If it is reciprocal depression, ST changes and T changes, it has to be a STEMI. ठीक है? Clear. So are you all in sync with me? Lead 1 and AVL has ST elevation. And the reciprocal change of 1 and AVL is seen in AVR as ST depression and T wave inversion. Am I clear? So it is a lateral wall MI. Am I clear? And the culprit vessel is LCX, left circumflex, which is originating from the LAD. Am I clear? Is this clear? Is ECG number 2 clear? Very good. Come to ECG number 3. Now this tests, trust me, these 4 ECGs, your localization is complete. Iske baad you have to see ECGs. The more ECGs you see, the more quicker and faster you get. ECG number 3, everyone, I'm already starting to get answers. So 3 May, the first ECG that you have, 3 May, somebody is saying V1 to V4 has ST elevation. Okay. First of all, my dear, it is not ST elevation in Dr. Geetika. Dr. Geetika, beta, the first ECG of number 3 is not having ST elevation in V1 to V4. Where are you finding ST elevation? In fact, V2 has ST depression, beta. Dr. Geetika, V2 has ST depression. How are you saying it's a elevation? Beta, एक बार ध्यान से देखो. Geetika, see it properly, beta. V1 to V4, you cannot have ST elevations. Geetika, the first ECG. Geetika, number 3, ECG number 3 का एकदम ऊपर वाला ECG. Can you find ST elevations in 2, 3 AVF? First, tell me this. Gitika, 2-3 AVF, does it have ST elevation? Gitika, can you see the... Yes, fantastic. So 2-3 AVF has ST elevations. Once I have 2-3 AVF as ST elevations, can I call it as an inferior MI? Yes, it is an inferior MI. Now, what is the culprit vessel mainly in inferior MI? It can be RCA, it can be LCX. But if I have to see whether it is RCA or LCX, what is the immediate next thing that I will do? As I said, any staff nurse will immediately check V4R. Immediately check V4R. And V4R, can you see this? Can you see this third? This one. Is everyone able to see my pointer? Is everyone able to see my pointer? Yes. Can you see this ECG? Yes, ECG. Gitika. Very good. Dr. Jayesh, very good. V4R. Can you see this? V4R is the exact equivalent of V4 on the left side. Can you see now? You are having significant ST elevations. In fact, you are having ST elevation in V1, V2, V3, V4. All of them have been placed on the right side now. If you see, all of them have been placed on the right side. Can I find ST elevations in V1 to V4 now, having placed them on the right side? Yes. So this is clearly a case of right ventricular MI as well. So inferior wall MI with a right ventricular MI has to be due to which artery? RCA or LCX? Inferior MI with a right ventricular MI has to be exactly, very good. Dr. Jayesh, Dr. Adarsh, it has to be due to RCA. Very good. And now that I have seen it is inferior, it is also involving the right ventricle. Should I also check out whether it is a posterior MI? Should I also check out whether it is a posterior MI? So on the ECG, this ECG where you can find my pointer pointing towards this ECG now, this ECG, do you find this that there is a tall R wave in V1? Do you find there is a tall R wave? Just give me a moment. Where is my pointer? Yes. Do you find a tall R wave in V1, V2? Do you find a tall R wave? So can I say that this patient has total right coronary artery involvement? Can I say it has involved the main trunk of the RCA, thereby leading to an inferior MI, thereby leading to a posterior MI, thereby leading to a right ventricular MI as well? Gitika, is this clear with you? I'm mentioning your name repeatedly because you were getting this wrong. ठीक है बेटा, nothing to feel bad. ठीक है? So also let me give you another thing. Just see this ECG. I think there's some problem with my pointer at times. Yeah, can you see this ECG? You are having ST depression here. You're having ST depression here. So a tall R wave in V1 with an ST depression. Tall R wave in V1 with an ST depression. Does it again lead me to think that ST depression in V1, V2, tall R waves points me towards a posterior MI? Am I clear? Yes, Dr. Jayesh. Perfect. So this ECG, which initially was looking as an inferior MI, I took V4R. I found that's a right ventricular involvement. I then took a case of I then saw the V1, V2, V3. I found there's tall R waves with reciprocal ST changes, and I can now say it's a case of inferior, posterior, as well as a right ventricular MI. So my main culprit artery is the right coronary artery. Is it clear? Is it perfectly clear? Anyone who has got a doubt in this? Anyone who has a doubt in this? Okay, okay, fantastic, fantastic. Okay, now, okay, now, this question is something that I want you to see. So, a 51-year-old male, recurrent chest pain after a STEMI, and 4 days after a STEMI. The chest pain radiates to the trapezius and is worse with deep inspiration. The pain wakes him up from sleep and has improved slightly after getting out of bed. Troponin levels were unchanged. When I say it's an unchanged troponin, can I therefore say it cannot be a reinfarction? Can I say that the troponin levels are unchanged? It is not a reinfarction. Very good. It is not a reinfarction. Now, since the troponin levels are unchanged, it is not a reinfarction. What is my next thing that I'll see? The ECG showed new ST elevations in inferior and lateral leads. Do you now realize that new ST elevation? So ST elevation का एकमात्र cause STEMI नहीं हो सकता है. There can be other causes of ST elevation as well, apart from just being ST elevation MI. So is option A ruled out? इतना बताओ मुझे पहले. Is option A ruled out? Everyone happy? It's not A. Definitely not A, because troponin levels are unchanged. Can I clearly say it is not A? Okay, good. Now there's a doubt between B and C. D तो वैसे भी उड़ गया. D I cannot. There is nothing evident enough to talk me about D. Now everyone is talking about B versus C. Okay, so this is why exactly I've placed this slide here. So it is indeed a case of pericarditis. Now, what is the timing of pericarditis following MI is what will decide whether it is early or late. The late is what we call as Dressler syndrome, that happens 1 week later usually. In the first week, the most common cause of pericarditis, so this new ST elevations in inferior and lateral leads are mainly pericarditic changes. That is again what leads me to my first slide. Every ST elevation is not a STEMI. A normal ECG does not rule out STEMI, just as ST elevation on ECG does not show STEMI. Am I clear? Am I right? Again, I'm proving whatever I taught you, I'm proving it through clinical scenarios. So this patient, because the chest pain has started 4 days after a STEMI, it is more likely in form of early pericarditis, and early pericarditis is not Dressler's. Okay? In early pericarditis, you will have chest pain, you will have a pericardial rub, which is a particular sound like, I wish I could make you hear it right now, but you can go to Google at any point of time and hear pericardial rub ka sound. It's a classic sound, as if you are rubbing your pencil on a sandpaper. ठीक है, एकदम बिल्कुल वो sound आता है. ठीक है, that sound, and you will have mild pericardial effusion. ECG will show global ST elevation. I repeat, this is the major thing that differentiates a STEMI from pericarditis. Pericardite in STEMI, you will have a localized ST elevation. Why localized? Because I told you in STEMI there is acute obstruction, no flow. So it will only involve a local area transmurally. लेकिन एक छोटू सा part involved होगा. You can localize कि ये inferior wall है, ये anterior है. It's a septal MI, it's an anteroseptal MI, it's a anterolateral MI, it's a lateral MI. You can localize it. But in pericarditis, you will find ST elevation in all the leads, and you will find PR segment depression. So new ST elevations in inferior and lateral might make me think, is it a new MI? But my cardiac troponins are unchanged, so it cannot be a new MI or a recurrent MI. It has to be something between early and late. Because it is in the first week, it is more likely to be an early pericarditis. Late pericarditis happens after 1 week, usually in the first month, which is mainly an autoimmune reaction, which is also called Dressler syndrome. There are other features also in this patient, like fever, you have arthritis, and a very classic thing is, because it is an autoimmune, it's an inflammatory condition, ESR and CRP is going to be raised. Okay? Everyone clear with this? If you are clear, I'll ask you a bonus question. If you are clear, I'll ask you a bonus question. Everyone clear why it is not Dressler's? Clear why it is not Dressler's? Acha, one question which is not related to this topic. Ek chotu sa question. I'll just want to know the answer. So in any inflammation or in any inflammatory condition, ESR and CRP are usually elevated or low. Just write to me in the chat. In any inflammatory condition, you have ESR and CRP, which is elevated or low, high or low, elevated. Okay. Can you name me one inflammation or one inflammatory condition where CRP is high, but the ESR is low? It is not low, it is normal. I mean, this patient will have a CRP of around 200, 300, even 450, but the ESR will be normal. And trust me, I saw such a patient just 1 month back. Anyone who can, no, not acute conditions, even in acute conditions, ESR, CRP will be high. I am talking of a case where CRP is in the range of 300, 400. Normal value is 0 to 6. In this case, CRP is around 300, 400. ESR is normal. Dr. Sneha, are you there? Can you try this out? The other ones? No, not viral. Viral, maybe you have high ESR, high CRP. I am talking of a condition where you have high CRP but normal ESR. No, it is not autoimmune. No, it is not autoimmune. No, not septic arthritis. Septic arthritis will come with ESR CRP. No, not at all rheumatoid arthritis. Both ESR CRP is high in rheumatoid. Not at all. Have any one of you heard of this called macrophage activation syndrome? Also called HLH, hemophagocytic lymphohistiocytosis. Have you heard of this? I'm writing this here in the chat. It is called HLH or MAS, macrophage activation syndrome. Anyone who has heard of this? Okay, I want you all to read on this. Okay? So I'm giving you a scenario. Usually in snake bites, mainly the neurotoxic snake bites or the vasculotoxic snake bites, you have HLH developing. I want you all to read on this HLH. It's also called macrophage activation syndrome. Kuch nahi. If you have Robbins with you, just go and search there, or you can search in Google. You have ChatGPT these days. This is the only inflammatory condition in our body where CRP is very elevated and ESR is normal. Snake bite is one of the causes of HLH. There are many other causes, many other causes. This is one of the causes. And I encountered a patient of HLH just a month back. So I just felt like asking this to you. Why is ESR normal? Yes, dengue can lead to HLH. Very good. Dengue can lead to HLH. The one reason why ESR is normal is in macrophage activation syndrome or in HLH, fibrinogen levels are almost zero. Because of low levels of fibrinogen, the blood usually cannot sediment at a higher rate. So ESR is normal. This is just a topic which I wanted to touch on because I felt this might create some interest. It's an inflammatory condition where ESR is normal, but the CRP is very high. It is HLH or MAs. Please read about it. Okay, chalo, let's move to the next slide. So yes, so this is what I was talking of in pericarditis. You have a global ST elevation. Can you see ST elevations here, here? You have ST elevations all throughout. Can you see this? Can you see the ST elevations? I'm clearly telling you the leads also where you'll be finding ST elevations. Can you see? There is no reciprocal ST changes. There is no reciprocal ST changes. Can you see that very clearly? Can you see that? Can you see V4, V5? Even you have V3 is having ST elevation. You have lead 3, lead 2. All of this has ST elevations. And can you see very clearly that this ST elevation is more of a concave up type? It is not the one that we were seeing in STEMI. In STEMI, it is convex up. Hence, STEMI, because it's convex, it looks like a tomb. And we say it is the graveyard appearance or the tombstone appearance. Because it is enough to lead a patient to dying. Okay? Pericarditis, you will usually not die. Okay? So you have a global ST elevation with a PR segment depression. That is pericarditis. Usual causes can be viral. It can be mainly due to Coxsackie virus, mainly due to Coxsackie is one of the leading causes of viral myocarditis. To be honest, I encountered one of my cases where it was my best friend who expired. She had Coxsackie infection that led to pericarditis and myocarditis. Apart from that, uremia is a cause. Post-MI is a cause. Some cardiac procedures can lead to pericarditis as well. The typical feature is this will be a chest pain which will increase on lying down, but will be relieved on leaning forward. And because of this, the patient will usually not want to lie down. The patient will usually sit up and will try to lean forward and will say, this is the position where I'm finding a lot of relief. Troponins are going to be normal because this is not an MI. The 2D echo will show me mild pericardial effusion. Management is by NSAIDs and colchicine. Colchicine has been shown to reduce the recurrence of pericarditis. But alternatively, you can also use corticosteroids. There is one molecule which is anti-IL-1, which is called anakinra. It is a monoclonal antibody that has been used as well. But what if this pericardial effusion starts growing very fast, acutely in a very short span of time? That is when we come across Mr. Salman Khan, the big brother of acute pericarditis. Can you see this? This is a case of pericardial effusion. Can you very clearly see on this X-ray how big the cardiothoracic ratio is? It looks like a money, but answer to high CRP and normal ESR. Dr. Payal, it is HLH or MAS. I'm writing it again. It is MAS, also called HLH. ठीक है बेटा? Yes. So it's macrophage activation syndrome, also called hemophagocytic lymphohistiocytosis. Please read on this. So as I said, as the pericardial effusion starts growing in time, and if it is acutely growing, it will lead to a picture called cardiac tamponade. Are you aware of this term, cardiac tamponade? Anyone? Pericardial tamponade. Are you aware of this term, pericardial tamponade? Yes. Can you see this X-ray? Can you see this X-ray here? How big the cardiothoracic ratio looks? It looks like, it's like a water bottle. So the the cardiac shadow appears like there's been a bottle which has been filled with water, and something that you get on echo. Can you see this echo very clearly, that the whole heart is just moving like this? There's no contraction. Can you see that the heart is moving as a whole? There's no contraction of the chambers. Can you identify this? Can you see the echo now? Do you feel good by looking at these echoes? They look real-time echoes. Are you feeling good? Because till now you may not have ever seen an echo. This is the first time probably you're getting a hack to see an echo. Can you see that the whole heart is moving? I'm going to play the GIF again. Can you see that the whole heart is moving from left to right? It is not contracting. The walls are not contracting. Usually the chamber should be contracting like this. Here the walls are not contracting. It is just moving as if it is floating in a ball, as if it is floating in a pool of liquid. And that fluid is the pericardial effusion, which is contracting it from all the sides. It's dancing. Exactly. It's dancing. And what do you find on the ECG? On lead 2, which is the rhythm strip. So anytime you need to check heart rate, arrhythmias, we'll always look at rhythm in the lead 2. So lead 2, which is the rhythm strip, can you see some appear taller, some appear shorter, followed, each following one another. Taller, shorter, taller, shorter. This combination of high and low voltage QRS complexes is what we call as an electrical alternance. Electrical alternance. Alternance means alternating pattern of high and low QRS complexes. Am I clear? Am I clear? Am I clear? Everyone's clear? Along with this, these patients also have something which is called the typical Beck's triad. What is Beck's triad? Beck's triad is a triad of hypotension. So this patient will come to you with low BP. You will have muffled heart sounds. When you place your stent, you will not be able to understand the heart sounds properly. And the best part is these patients will also come to you with, just give me a moment. Just give me a moment. Yes. So these patients will basically come to you with the typical Beck's triad. And once you have Beck's triad is a typical combination of three things. One is hypotension. Along with this, in these patients, you have muffled heart sounds, and you also have a distension, which is very, very, very clearly seen of the jugular venous waves. So jugular venous distension, hypotension, and you have muffled heart sounds. This combination of a triad is what we call as the Beck's triad. So this patient will come to you in an acute state with chest pain, with shortness of breath, and this on ECG you will find electrical alternance. Is this clear? This is what we call as cardiac tamponade. The management is very simple. You have to do a pericardiotomy. Okay? If the patient is unstable, you have to put in the needle through the xiphisternum and you have to suck out the fluid basically to relieve the pressure on the pericardial sac. Please do not confuse it with another entity where you do have hypotension, you do have jugular venous distension, but instead of muffled heart sounds, you have something which is called as silent chest, which is absent breath sounds. Absent breath sounds, muffled heart sounds will differentiate Beck's triad from the triad of pneumothorax. Beck's triad will have hypotension, jugular venous distension, which is also there in tension pneumothorax. But muffled heart sounds will make it a diagnosis in favor of Beck's triad, that is in cardiac tamponade. Am I clear? Am I clear? Am I clear? Is this clear with everyone? Okay. The last two slides, one is this, where I have talked of pneumothorax, and the last one where I've talked of pulmonary embolism. These two slides are the last two slides of the day. So the first thing that I'll talk of here is pneumothorax. Now, what is pneumothorax? In pneumothorax, if you clearly see this GIF, I'm clicking here on this GIF. Just give me a moment. Yeah. So if I click here on this GIF, can you clearly see that something is compressing the left lung from outside? Suppose there has been a stab injury to your chest. Suppose there's been a stab injury to your chest and the blood or the air from outside is now seeping into your pulmonary cavities. Are you able to understand? Suppose there's a stab injury to your chest. Once there's a stab injury to your chest or there's a trauma, now that opening which has been created due to the knife stab is sucking in the atmospheric air, and that atmospheric air is going to crush down your lungs, which is shown in this image in the animation down. Is everyone able to follow it? Can you see that the left lung is collapsing? Can you see that the left lung is collapsing? Are you also able to see that along with the left lung collapsing, it is pushing the heart and the mediastinum a bit to the right side? Are you able to see that? Can I have the answers in the chat? Dr. Twinkle, thank you. What about the others? What about the others? Who did not understand? Please let me know again. I'm again letting you know. Suppose you have been stabbed in your chest on the left side. If you have been stabbed in your chest on the left side, that hole that has been created is sucking, because atmospheric pressure is higher. It will suck in that atmospheric air, or if it's blood, it will suck in that blood, and that blood out of the air is going to literally compress the left lung. Is the animation visible to you? Is the animation visible to you? Is the animation visible where it is compressing the left lung? Do you see along with the compressing or collapse of the left lung, it is also pushing the right lung and the mediastinum towards the right lung? Can you see that the heart is being pushed to the right side? Exactly. So anytime you are having this patient with a chest pain, sharp chest pain, which is worsening on inspiration, I'm giving you another hint, a chest pain which is worsening on inspiration, patient is a known history of an injury or trauma, or he's been a tall male with Marfan syndrome, smoker. All of these are risk factors for pneumothorax. How do you understand which is a pneumothorax lung? How do you understand the side of pneumothorax? Can you see this X-ray? In this X-ray, do you see that the two lung fields on here, the left lung appears to be having more visible markings? Can you see white markings in the left lung? These are bronchovascular markings which are due to the blood vessels at the hilum. But if you clearly see the right lung, do you see after this is the border? Can you see this border that I'm trying to draw? Beyond this border, there is nothing. Beyond this border that I'm trying to draw, there is nothing. So only this part is the lung, whereas this is the part that where the air or the blood has started to seep in and it is compressing the lung. So basically this entire thing is the left lung, but only this much is the right lung. Is everyone able to appreciate this? Is everyone able to appreciate? Yes, the absence of bronchovascular marking is making it more black. What is black? Is it hyperlucent or hyper opaque? Anyone? What is black? Hyperlucent or hyper opaque? No. It is hyperlucent. Black is lucent. Hyperlucent. Black is lucent. Beta, on radiology, on CT, X-ray, hyperlucent is black. Okay, beta. Lucency is black. Okay. Now, so this is exactly what is happening in pneumothorax. When I'm doing an ultrasound, see, this is the chest wall. Okay, dekho, chest wall is moving. See, the chest wall is moving. Just give me a moment. Yeah, so you see the chest wall is moving. But do you see that this point on the lung is not moving in synchrony with the chest wall? See, the chest wall is clearly moving, but the lung does not seem to move. Are you able to identify on the ultrasound that the chest wall is moving, but the lung does not seem to move? The exact point where it has been pointed with the white arrow. This thing is what we call as the lung point sign. It is a very diagnostic thing that we do in the ER. If you're having what is called a POCUS is point of care ultrasound. It's a bedside ultrasound machine. You directly put it and you can see whether the chest wall, usually this is supposed to be the motion. Can you see my hands? Can you see my hand movements? Is my hand movement visible? So usually this is what happens. This is the chest wall and this is the lung. This is the lung, this is the chest wall. It's a gliding motion. But here do you see that the chest wall is moving, but the lung is not moving. The lung is not moving. This point is called the lung point sign. And if I'm doing, these are all ultrasound. Okay, repeating the movement. This is supposed to be the movement. This is the chest wall motion and the lung is supposed to glide. Opposite. Essay. This is the movement. But in pneumothorax, this movement never happens. So it's still the chest wall is moving. Please see this animation. You can clearly see this, that there is a point where only the chest wall is moving, but the lung does not move. This is called the lung point sign. Adarsha, I'm repeating again. Usually the chest wall and the lung will move in synchrony, but in pneumothorax, because the lung is collapsed from outside by blood or by air, the lung will stop moving. Only the chest wall will move. Usually this is the movement, lung, chest wall, this. But here we will have a condition where lung will stay still, chest wall will move. This point is the lung point sign. Dr. Adarsh, is this clear? Dr. Twinkle, yes, we will. No, we will not do thoracoscopy. We will do thoracotomy, my dear. Dr. Twinkle, it's thoracotomy. This is the point where you will try doing the thoracotomy. You will open this up. I'll talk of it in just a moment. In just a couple of minutes, I'll talk of this. On USG of other two signs, one is the seashore sign, one is the stratosphere sign. Seashore sign is what we usually see normally. You know, normally हम लोग sea shores पे जाते हैं ना, हम लोग घूमने sea shore पे normally जाते हैं, right? But what is seashore? This is the in seashore sign. This, you see this granular sand like appearance. This is the lung, whereas this is the chest wall. But see now, entire, there is nothing called lung. Can you see? Can you see in the stratosphere? The entire thing looks like a barcode or a stratosphere. Barcode sign. It looks like a barcode, which means nothing of the lung is present there. The lung has been collapsed. So seashore sign is a normal finding of a normal lung where you have a barcode like C, which is the chest wall, and a fine granular sand like structure, which is the lung. But in a stratosphere or barcode sign, you do not have this differentiation. It is entirely the chest wall because nothing of the lung is there. It has collapsed. Am I clear? Am I clear? Everyone clear with the seashore and the stratosphere signs? So the lung point sign, seashore, stratosphere, all are USG findings. Seashore is a normal finding. Lung point and stratosphere are abnormal findings found in pneumothorax. Okay? As I said, there will be pleuritic chest pain. It will be hyper resonant on percussion. So tension pneumothorax, and I repeat, tension pneumothorax and cardiac tamponade, very similar. There will be jugular venous distension, both the cases. There will be hypotension in both the cases. But muffled heart sounds makes it cardiac tamponade. Absent breath sounds with hyper resonance on percussion. When you percuss, you will find a resonant note like tung, tung, tung. It will seem like you're playing a vessel. That's exactly how you will sound. Okay? So that is exactly what is tension pneumothorax. The management is very simple. Because it is the outside air or the blood inside which is collapsing the lung, you need to take that blood out or you need to take that air out. Can you now follow my pointer to this, where we have, where can you see this patient had a stab injury and this blood is being relieved out of the lung? Can you see the blood is being relieved out of the lung? Can you see that the blood is being relieved out of the lung? Just a minute. Can you see here that the blood is being relieved out of the lung? Once the clamp is being removed, can you see that the blood is being relieved out of the lung? Is this visible to everyone? Everyone, I'm waiting for your replies in the chat. Everyone. Thank you. Thank you so much. Okay. Now, so the management is very simple. You insert a needle. In case of tension pneumothorax, you insert a needle. You go in the triangle of safety, which is, you can see the boundaries here, anatomical boundaries. I'm not reading it because it's directly written there. You insert a needle, and following that, once you insert the needle, the pressure starts getting relieved. But you cannot just leave the needle there because again blood will start accumulating because it's an injury that has happened. So you need to insert an ICD. Yes, correct, Dr. Twinkle. You need to insert an ICD, which is an intercostal drainage. Through that ICD, the blood or the air, whatever is there, it comes out. And mind it, don't do this mistake. You have to put that ICD in an underwater seal bag, because that will maintain the pressure gradient. So you'll basically take a bottle. How many of you have watched Good Doctor? How many of you have watched Good Doctor? Good Doctor, first episode of Good Doctor. If not, please go to Netflix or Amazon Prime or YouTube. Even there you will find the first episode. So the first episode where Sean is treating, that's the case of a tension pneumothorax. Okay, you keep a bottle and you pour some water in it to a certain level. You connect the ICD and put the end of the ICD in that water bottle so that the bubbles come up and create the pressure gradient. Okay, that is the management of pneumothorax. Needle thoracotomy with ICD. Okay, yes, it's a one-way valve. Very good, beta. Shreya, very good. It's a one-way valve. Very good. Okay. Now, the last topic of the day. It is pulmonary embolism. So when I talk of pulmonary embolism, there are certain risk factors for development of any venous thromboembolism. Any thromboembolism occurs due to a certain triad which is called the Virchow's triad. Anyone who has heard the name of Virchow's triad? Pathology, second year days, Virchow's triad, hypercoagulability, stasis, endothelial injury. Does it remind you of your second year days? Yes. So Virchow's triad says whenever there is a hypercoagulability, because of high coagulable factor, because of the high coagulable properties, the blood will not flow properly. There will be stasis. Because of the stasis and hypercoagulability, there will be endothelial injury. This is exactly the pathophysiology of any venous thromboembolism. Okay? Yes, protein C S deficiency. Yes, fantastic, Dr. Twinkle. Good. So now, major risk factors to any venous thromboembolism is what you have in this box, green colored. You have mainly lower limb surgeries like the hip surgery, knee replacement surgeries, any major trauma which is keeping you bedridden for at least more than 3 days for a minimum of either 2 months bed rest or minimum of 3 days bed rest. Any long flight duration, have you anytime, if you would have surfed the news recently, I think 1 or 2 months back, there was a case of pulmonary embolism which happened in the aircraft because of a traveler who was having almost a 12 to 13 hour flight, and that person did not move. Because today most flights in the business class, in the economic class, will keep you with Wi-Fi. And once you have a night time, everything is comfy, the curtains are raised, you have Wi-Fi, you are onto Netflix or some other websites, you will literally not move your limbs. Okay? And if it's a 12-13 hour flight, in that altitude, in that pressure, it is very, very, very highly predisposing to developing a venous thromboembolism. So bed rest for more than 3 days, any immobility or prolonged air travel, okay, increased age, pregnancy, which is in itself a hypercoagulable state, protein C, protein S deficiencies, chemotherapies, any malignancies, any inherited or acquired thrombotic defect, coagulation defects lead to a risk factors of venous thromboembolism. Now, what happens in the venous thromboembolism? Usually, you will have an asymmetric calf swelling. Please, please, please remember this. It's an asymmetric calf swelling. But asymmetric calf swelling does not always mean DVT. It can also mean cellulitis. It can also mean edema. But usually, when you have an asymmetric calf swelling with pain and redness, you have to do something which is called a USG color Doppler or a duplex scan to see the flow of blood in the vessels. Mainly, if it is a venous thromboembolism, it will involve the proximal veins like the popliteal veins and above. Matlab popliteal, femoral, gluteal, all of those veins will be involved. Whenever this thrombus is going to embolize and move distally into the lung circulation, that is when we encounter a deadly situation called pulmonary embolism, where you have an unexplained shortness of breath, chest pain with or without hemoptysis. In fact, any patient in the ICU, I'm telling you a dictum, any patient in the ICU after a surgery or any kind of malignancy, if this patient develops unexplained shortness of breath with chest pain, it is pulmonary embolism unless diagnosed otherwise. I'm repeating, any patient in the ICU who has been immobilized with a hip or a lower limb surgery or with malignancy, who is immobilized for at least 3 days and develops a new onset chest pain, unexplained shortness of breath, it is pulmonary embolism unless otherwise diagnosed. Okay, beta? Clear? So you will find these patients to be really in need of urgent treatment. And what you find is on ECG, very common. Yes, I'm going there, but I'm going there. In ECG, usually the ECG will stay normal. The most common finding is a sinus tachycardia. You may also have other findings like S1Q3T3, but please notice S1Q3T3 is not a specific feature of pulmonary embolism. I have myself encountered 5 to 10 pulmonary embolism cases where only one had an S1Q3T3, 9 of them did not have. Trust me, S1Q3T3 is not a specific feature of pulmonary embolism. S1Q3T3 only shows that the right ventricle is under some strain. it shows that the right ventricle is under some strain. What is S1Q3T3? Deep waves, deep S waves, deep negative waves, that is S waves in lead 1. Q waves, sorry, deep positive waves, S waves in lead 1, deep negative Q waves in lead 3, and inversion in T wave, या फिर T wave inversion in lead 3. That is S1Q3T3 pattern. So S1Q3T3 pattern only shows a pattern of RV strain. But as Dr. Twinkle says, tachy is very difficult to interpret. Exactly. So ECG is usually non-specific beta. You have to look at the clinical features, whether this patient is in a already predisposed state of hypercoagulability. Is he having some underlying malignancy? Is he having already, is there a case of deep vein thrombosis? In fact, what is the most important risk factor for pulmonary embolism is a history of prior deep vein thrombosis or a history of prior venous thromboembolism. That increases the risk by 10-folds at least. Okay, so in a patient who is already having a recurrent history of thromboembolism or a venous thromboembolism or a DVT in the leg, you should always be suspicious that this patient is coming to me with a chest pain or unexplained shortness of breath. I have to once evaluate. Chest X-ray, again, very non-specific, but these are very favorite questions of your Viva examiners. Trust me, in theory, they love asking these questions because Indian examinations always pay attention on the less important stuff. I don't know why, but then that's how it is. Indian examinations love S1Q3T3, which is very non-specific. They love X-ray findings, which is very non-specific. Okay? So you may either get a Hampton's hump, which is a wedge-shaped opacities, you can clearly see. You may get Westermarck sign, which is a sign of focal oligemia. Oligemia matlab low blood flow. So low blood flow to the lung will make it more black. Okay? Every black is not pneumothorax. See whether the black has a border. If the black has a border separating it from the normal usual lung, it is pneumothorax. If it is just a small region of black, it is not pneumothorax. It is a focal oligemia, which is Westermarck sign. Because once there will be a pulmonary embolism, that part of the lung will not be supplied by blood anymore, right, my dear? So that is going to lead to Westermarck sign or focal oligemia. And the third sign is an enlarged right descending pulmonary artery. This thing which I want to show. Where's my monitor? Yeah, this is my pointer. Yeah, this thing. This swelling is the right descending pulmonary artery, which is called the Palla sign. But trust me, none of these are specific findings. None of these are specific. Now, you can have a pulmonary embolism coming in a high-risk patient where the systolic blood pressure is less than 90, or this patient can be an intermediate risk where blood pressure is less than 90, but the RV strain is found. I mean, systolic blood pressure is more than 90, but the RV strain is found on echo or on ECG, either as S1Q3T3 or on echo, you are finding that there is an RV strain. Or it can be low risk where neither of the features are present. You need to evaluate it. And the evaluation is my last slide of the day. How to evaluate a case of venous thromboembolism. So please note, if you are having a case of venous thromboembolism, I mean a patient has come to you with pain, asymmetric lower leg swelling, there is no fever, you are not thinking in lines of cellulitis. If you're, and you know the risk factors of pulmonary embolism are also not there, then it is a low risk. If there is a low clinical suspicion, you go with D-dimer. In D-dimer assay, if it is negative, D-dimer usually comes as a value of up to 500. Agar 500 se niche hai, then you can rule out venous thromboembolism. But if D-dimer is high, you immediately go to imaging. The imaging can either be in the form of a compression ultrasound, where you will find veins. Veins should usually be compressible, right? But in case of a deep vein thrombosis, because of the thrombus, the vein cannot be compressed anymore. Hence, it comes as a non-compressible vein. You can have CTPA, which is the definitive diagnosis. In CTPA, you can see this arrow mark showing a filling defect of contrast. This is a CECT where all the vessels, this is the SVC, this is the main pulmonary, this is the ascending aorta, and this is the main pulmonary artery. SVC, ascending aorta, main pulmonary artery. This is a SAM structure. We call this as the SAM structure on CT. S for SVC, A for ascending aorta, and M for main pulmonary artery. Can you see that in the main pulmonary artery, everything is white because it has taken up the contrast, but this one segment marked with an arrow is having a filling defect. This is what we call as the saddle embolus. Or in patients who have renal failure, hence you cannot give the contrast because they are having high urea creatinine values, you will go for a VQ scan, ventilation perfusion scan. There you can clearly find that this part of the lung is very well ventilated, but this part of the lung is not ventilated. However, it is perfused. There is a perfusion ventilation mismatch. Because of low perfusion to that part of the lung, the ventilation has been wasted. Can you see this? There is a VQ mismatch in the lung. So this is exactly what I mean by imaging. Okay? How will we involve D-dimer? Yes. So again, as I said, my dear, you have to have a clinical. So your clinical suspicion, if is this patient having chest pain and shortness of breath, is this patient already a patient of lower limb surgery? Is this patient already a case of malignancy? If yes, I will have a high suspicion. If not, I will have a low suspicion. If it's a low suspicion, I will do D-dimer. If D-dimer is negative, I will rule out VT. VT means venous thromboembolism. If it is high, if the D-dimer is high, and or if I have high clinical suspicion, I will do CTPA. If I find the embolus, I will treat accordingly. What if my clinical suspicion is low, but I mean, there is no venous thromboembolism, but I am suspecting a pulmonary embolism, which means this patient does not have an asymmetric limb swelling, but there is an acute onset unexplained shortness of breath. Means I am not worried about DVT. I am worried about pulmonary embolism. That is exactly where the PERC criteria comes in. Now, why have I kept this criteria? This is the modified Wells criteria, which is absolutely of no use in clinical practice these days. Only theoretically examiners love asking you Wells criteria. So I'll not talk of this criteria. I'll only talk of this criteria, which is PERC, which we are using in clinical practice. Either you have 8 parameters here. Okay? Age more than 50, heart rate more than 100. You can read all the parameters. Prior history of venous thromboembolism. If even one out of these 8 is positive, we will go for a D-dimer. Again, in whom? Where the clinical suspicion is low, but the patient's symptoms are making me think that there is a pulmonary embolism which is being suspected. Okay? In all of these conditions, I will have to think that this is a case where I will have to look at the PERC criteria. If even 1 out of 8 is positive, I will do D-dimer. If D-dimer is high, I will go to imaging. But if all 8 are negative, see, 1 out of them being positive shifts your diagnosis towards thinking towards pulmonary embolism. But if even all of them are negative, that is when you can rule out VT. So PERC criteria was actually done in patients with low suspicion of DVT, but a high suspicion of PE. If in these patients, even one of these criteria is positive, go to doing D-dimer. If it is positive, do imaging. If not, you can rule out VT. That in a nutshell is all about what I had to talk today. And that is predominantly talking of all the emergencies that I could have talked of, because what I really feel is in practice, even if you miss a musculoskeletal cause, even if you miss out any other cause, you will actually not be guilty of not being able to treat a patient. But it is actually when you miss out the real fatal causes that you start losing a life. And it is only imperative that I could give you a not so brief. I know I was kind of teaching you because not everyone has got that exposure to understanding ECGs. And I repeat again, when you rewatch my lecture today on YouTube, please go there, put in your comments. If you have doubts, write down there, show your love, but keep that note so well in your mind that you can go to the hospital and from tomorrow or day after, go to the hospital, look out for patients of ACS, get the ECGs, just diagnose the ECGs. Trust me, as an undergrad or someone who is just past MBBS, if you can localize ECG territories and say which vessel is having a problem, even without doing an angio, if you can just read the ECG and do it, it will be a great deal of expertise, which is unbelievable. Trust me. I've tried helping you. I've tried showing you how to do it. It is now your work to build on it. And I hope I have been able to answer to all your queries. I hope I've been able to, as a first year, okay, there's a first year student here, Dr. Jayesh. Thank you so much. Thank you so much. Saprikta, thank you so much. It means a lot. Thank you. To everyone else, I'm not able to read all your names. And I'm so glad that you have been there. Almost 90 to 100 people still there. I know it's been a long session, but what I always try is it should not be a case where you hear a webinar and you go away home thinking, "Yaar, aaj kya padhaya? Mujhe samajh mein nahi aaya." I want to deliver it to a place where you are able to understand and you're able to build on from it. So even my brothers and sisters who are from your first years, trust me, you will have a lot of confidence. Just don't forget this and go to the wards, see patients, because patients are going to be your real teachers, even bigger than me or any textbook or any professor on this earth. Go to the patients, look out for the patients of ACS, take their ECGs, read the ECGs. If possible, write them back to me on that, on any platform. I'm available on platforms, in social media. DM me your queries, anything. Trust me, this is exactly how we build up together, and that is exactly how we learn. So I give you all my love and a lot of regards. I hope I was able to be a good senior, a good elder brother, and I hope you all can be building upon this in future as well. And thank you to Mediversal again for giving me such wonderful opportunities where I can cater to such a lovely audience. It's been an absolute pleasure to have all of you. It's probably the best webinar that I've conducted today in all the last webinars. I think it's the best personally. The number jitna bhi maine conduct kiya hai, this is the best that I conducted because I have so much of response actively from all of you. So virtual hugs and lots of love to all of you.
Thank you so much, Dr. Navonil, for this insightful session. I hope everyone has enjoyed the session. And on behalf of everyone, I extend our sincere gratitude to you, Dr. Navonil.
I am not going to share my contact number. I think that will be that is not going to be possible somehow. But you can always, I mean, the team can help you with how
Yes,
to
doctor
contact
will
me.
help them through mail or
Yes,
something like
yeah,
that. That's not an
yes,
issue,
yes.
actually.
The certificate link, yes, you will get a signed certificate from me. And of course, in future, if you all can suggest, we can go on with how to treat MI cases, how to work upon stable anginas. We can always take on webinars on that. And you are the ones who has to give the feedback to the Mediversal team as to whether you liked me, how much you liked me, and what are the things that you would want as topics to be taken up. I think the team can do that in your feedback forms. Takotsubo ECG shows normal. Trop is normal. How can we diagnose? Good question. Okay, who's this? Dr. Yusuf. Thank you. I missed out Takotsubo. So, okay. ECG is normal. Trop is normal. Yes, but you find something which is called myocardial stunning. That's a property of Takotsubo. Okay. Also, on echo, you have apical ballooning. That's a feature of Takotsubo, which you will never get anywhere else. Okay. You have apical ballooning, which is a feature of Takotsubo. You can just Google this term. Wait, I'm writing this here in the comments so that you can do this. Apical ballooning on echo, and you have myocardial stunning. Okay. Okay, Dr. Yusuf, you can read up this. You can see the gifs of apical ballooning. You will clearly be able to understand that Takotsubo does not mimic anything. एक बार आप apical ballooning देख लोगे, आपको जिंदगी में दोबारा भी देखने की जरूरत नहीं होगी. It's one disease which is apical ballooning and looks like a pot, Japanese pot. It's Takotsubo. Yes, Dr. Yusuf, thank you so much. Need more lectures from me? Okay, thank you, but I'll surely try. The team will definitely take care of it. Thank you so much. Thank you, Mediversal. Yes, thank you, Mediversal. They really deserve a huge bit of thanks. Thank you. I hope there are no more doubts. If there's any more doubt, I'm giving 2 minutes. You can one request from my end. It's one personal request because I have tried giving whatever I could. It's my personal request. You will be getting a feedback form. Please write that feedback form and honestly write it. ठीक है, ऐसा नहीं कि बस भैया ने 2 घंटे से पढ़ाया है उनको 5 में 5 देना है. If you want to give me a 2 out of 5, give me a 2 out of 5, but please write why you gave me a 2 out of 5. I need to know that. ठीक है, I really want honest reviews. I want you all to write whatever you feel. ठीक है, if I taught well, write that. If I didn't teach well, write where I could have been better, and that is something which will really come to me. Okay, so please, that's my honest request. Do that, and I'll be hoping to meet you all very soon. Lots of love to everyone. Why Mediversal wants me to sign in? Somebody from the team has to cater to that.
Yes, doctor, I will look into this actually. It's not about sign-in, it's related to email only. It's not from Mediversal.
Okay. So please coordinate that. Criteria for thrombolysis in acute P abhi nahi kar sakta hu yaar. It's a big topic. Trust me. But I promise you, if we are having a continuation of this session, if you all suggest to the team कि we'll have a continuation of these sessions, I'll take a separate case on stable angina, chronic stable angina, acute management of MI, and acute management of PE. I'll do that. That's my promise. Better take some more sessions again. I'm more than willing, but yes, I'm very sure that the team will coordinate it that way. Thank you for all your reviews. I guess there's no more doubts. Good night to the others who are from different parts of the world, if not from India. Good morning, good day, good evening, whatever it is. I hope you have a good dinner, a good night's sleep, and it's the festive season coming up. Have a good time, safe time, happy time with your family, with your friends, and stay happy, stay blessed, all of you. Okay, the team, can I
Yes,
leave?
doctor, thank you so much. You can leave.
Yes,
Thank you so much for the session.
thank you so much. Thank you, Shabnam, Ifka, Vijay sir. I know many of you are not here, but lots of gratitude to each one of you. Thank you.
Thank you so much, Dr. Navonil. So I'll be sharing the certificate registration form again in the chat box. You can fill the form and you'll be getting the certificates in the mail ID. And for any further questions or if you want any more information, you can follow us on social media platforms. The link also I am dropping in the chat box. Thank you so much, everyone, and good night. And thank you so much, Dr. Navonil, once again.
Thank you. I'm taking leave, okay?
Yeah, sure.
Yeah. Okay.
Okay, bye.
Bye-bye.